Good. All right. Well, without further ado, I will have our first presenter, who is actually Karen Metzger, CEO, and she'll take it away here.
Good morning, everyone. How are you? Well, welcome to Gritman. Welcome to orientation. As John said, a lot of the stuff, you'll see some of the stuff in your binder on my presentation, but we'll just kind of walk through it. I'm not going to do my picture. So I'll tell you a little bit about myself. I actually grew up in Idaho. I grew up in Idaho Falls. When I graduated from high school, decided to come up to the University of Idaho to get a degree, and I decided to get a degree in accounting. During my schooling, about my last year, it was announced in the class about an internship here at the hospital. And when I was in Idaho Falls, I actually was a junior volunteer, and healthcare was interested in me. So I applied for the internship. I did that internship for my fall semester. In the spring semester, I came back just to help out with the accounting department, and shortly after that, the controller and the staff accountant decided to give notice at the same time. They left within the same week, and for different reasons. One was medical, the other one, her husband got a job back east. So I was hired at that time as an accountant, and so it was throwing myself right into the fire. Got a desk and said, here you go. And it was a great experience for me. So I started here as an accountant, did that for about 2 years, became director of fiscal services. After that was a director for about 4 years, became CFO for about 10 years, and then now in this role, this will be year 9 here coming up. So part of the reason I'm here is, and we'll talk about this, is our mission, vision, and values. One of the things I wanted to do is I didn't want to focus on the bottom line, even though I am an accountant. That was not what drives me as a person. I wanted to make sure that I was working for a company that gave back and had meaning. And so that's what drives me. And I found that here, and we'll talk about it in just a few minutes. Well, to tell you a little bit about Gritman, we actually were started by Dr. Gritman. Back in the late 1800s. He actually started it here on the corner of 7th and Main Street in what was the McGregor Hotel. There's a picture of that hotel that they converted into a hospital. Him and his wife, his wife was a nurse. They cared for the patients and actually lived upstairs in the hotel. And there's a lot of rich history with the Gritmans. Unfortunately, back in the 30s, when he retired, shortly after that, he passed away. And Bertie, his wife, actually gave the hospital to the community with the covenant that it had to forever bear his name. And back in the 40s, there was a lot of community involvement to build the hospital. So this wing right out here is our 1940-41 wing. So what they did is they ended up building the south side next to the McGregor House. Moved all the patients over there, tore down the McGregor House, and then built the north side. So we've been downtown as an anchor since the late 1800s. We've been serving the community for over 120 years and are very passionate about that. And I'll talk a little bit about what that is here in just a minute. To start off, we always talk about our mission, vision, and values. You do have a copy, and what we talk about it is our Gritman way. This actually was developed by our board of directors, and I'll talk a little bit about them here in a minute. And this is really our roadmap. As we're making decisions in the organization, we're always looking at our mission, we're always looking at our vision, and obviously our values are a huge piece of our culture. So all of you, when you apply, had to go through our standards of behavior, and that is not by accident, because we want to really live our values. And so it starts when you simply apply for a position, and you'll hear a lot about our values and what it means here at the hospital. So just to let you know about our board, so it is a community not-for-profit hospital. So essentially it is run by a community board. So we have actually 2 different boards. We have executive board, which is made up of these 10 members. And then we have a general membership board, which is made up of 40 different members, 10 of which are these individuals. The other 30 represent all of Latah County. And so what we do is every May we have a business meeting where those individuals are re-elected. So a general member only has a 1-year term. The executive board has a 3-year term, and so we have an election process. And what we try to do is we try to get representatives from all of Lake Clark County based on the population. And what we want to hear from them as a community board member is we want to hear how we're doing at the hospital in their communities, and if they need anything from on the medical side. So that's why you see clinics in Cambridge, clinics in Potlatch now, and in Troy because of that board and that program, and a lot of the initiatives. This last year, we actually had a change in our board chair. Dr. Craig White is our board chair. He works in our emergency department also. This is the first time that we know in history that we have a physician leading our board of directors. So a great time to do that. Obviously, one of the things that we talk about is our customers, and we identify our customers in 3 ways: our patients, and our physicians, and then each other in the room. And so really trying to focus on our physician relationship, and it's nice to have Craig in leading that role. This is something that we developed probably about 15, 16 years ago with our leadership, and we still use that. We refresh it. And I'll walk through what this is. And so when we developed it, the reason why we developed it is we heard from our staff at that time that they didn't know where we were going as an organization. And so we wanted to have some sort of different guideline to show everybody what we're doing. So I use this when I talk out to our community, when we talk to our board of directors, and we're talking to those general members. And to walk through this is the outer ring really starts with our mission, vision, and values. So that's what you'll see on the outer ring. The Gritman Way really talks about our culture of an organization. Obviously, we are a service industry. We want to make sure that we are serving our community and serving the individuals that are interacting with us, and that's why we focus so much on our values. The gold lettering is essentially our strategic pillars. And so we are in our last year of our strategic plan, and we'll be developing it this year, but these are the pillars that we're working on with the board of directors and the community board on some of our initiatives, and I'll talk about some of those here in just a minute. The gray area talks about kind of our stretch goals. What do we want to accomplish in that strategic plan? And they're divided essentially in our 3 customers for the upper 2, and then our financial piece. And so to walk through that is that one on the left is clinical excellence. And the way we measure clinical excellence, if you've been in healthcare for a long time, you can actually Google hospitals and you can find out how their quality scores are. So if you go under hospital compare, you can look us up and you can compare us to hospitals around our region. And essentially we want to be as expected or higher than that. And currently we are meeting all of those goals. If you do go out and look at it, there's some that we don't have enough patients, so they don't measure it, so they'll say anything. But for all the measures that we qualify and report for, we are as expected or higher in there. On the right-hand side, we talk about experience excellence, and that actually touches on 2 customers. One is our medical staff and our physicians, and we want to, we've been working on a medical staff development plan. So part of the initiative you saw last year, you saw that we hired a lot of physicians. It was not by accident, it was by working with the medical staff trying to identify services and gaps in needed new physicians. And so we've been developing that. We're going to continue to develop that this year. And then the other one is our employees. So we want to be at the 90th percentile for organizational and job engagement. So every May, we actually have our employees fill out a survey and rate us on how we're doing. Last year, we used a company called Press Ganey. Press Ganey actually bought the company we were using, which was called HealthStreams. And so it was a different survey for us, different questions, different benchmarks. And for that survey, we were at the 89th percentile. Now, the difference in there is HealthStreams was measuring about 350,000 employees. Press Ganey was measuring 1.6 employees. So our competition as far as how they were rating us obviously jumped up almost 4 times, and so, but we were really proud of that. We were at the 89% now. Prescott was surprised at having the first time survey that we scored as high as we did. And so what we encourage you guys is, as you see things, as you want things changed, we don't want to hear from you in May. We'd like to hear from you throughout the whole year. And so we want feedback on how we're doing as an employer. It's not by accident that you heard good things about us. It's because we want to continue to change and evolve and be the employer of choice in the region. So if you do have any suggestions, let us know so we can do that. And then that's where we need exceptional healthcare. That's how we measure it. It goes back to our mission. Any questions on that? Well, you will see this target throughout the organization. It's on screensavers, it's on the walls, it should be in your department. And then the last one is just the financial excellence. We measure ourselves by Standard & Poor's. And so our viewpoint is, if we focus on those top 2, the financial side will happen. So to talk a little bit about those strategic pillars and some of the teams, and we are in the new year, and so we'll be developing some more teams, and actually I talked about it at our staff, all staff meeting on Monday. But these are some of the teams that we'll still have in place, and some will change up a little bit starting Thursday. So we have a rewards and recognition team, and that team is really focused on you as employees. So we do have a party this Saturday. If you haven't signed up, I would sign up. It's a really fun party. It's essentially for the employees to celebrate our accomplishments, recognize you, and have a good time. And it's actually at the University Fitness Center. Because now we have about 560 employees here in the organization. With MFM, it's another about 90. And so we needed a lot more space to have those parties. The other one is our employee wellness team. That team's been in existence for a long time. And part of that is our healthcare industry over the last 20 years has changed. It used to be that you go to the hospital when you're sick. That's not what hospitals' mission is anymore. It's really to keep the community well. And that's why you see all the wellness initiatives. That's why we have our wellness center, cardiac rehab, and we are trying to keep our community well. And so that wellness team actually starts with our employee side. The IT team is just that, the technology team. They're always looking at different technologies that we can use to help get the information either to the patient faster or to our physicians faster for care processes. The VIP team is very important physicians, they're very important partners, and that team is going to become very active this year. We actually are starting 3 different teams. That team will kind of evolve a little bit, but what we're doing is we're creating teams around our 3 customers and really dividing our leadership. We have about 25 different directors here at the organization, and what we're asking them to do, we're splitting them up into those 3 customers. And actually having them look at the processes, what's going on with those customers from that perspective. So how are we doing when we talk about our patients? How easy is it to come in and get your lab test and get the results to you and to your physician in a timely manner? And so they'll be having a deep dive into that process. I've mentioned the Gritman Way team, and the revenue cycle is just that, looking at our revenue cycle. Our revenue cycle does not start in our billing department. It actually starts in our admitting department and goes throughout the process. And so we're trying to find ways to improve that and make sure that when the patient does get discharged, obviously the last thing they want to deal with is a bill that's not being billed with their insurance company right or having issues. And we want to make that as seamless as possible. The lean team, how many of you have worked with lean or know what lean is? So lean actually was developed in the manufacturing industry years ago, where they look at processes. And Henry Ford used it when he was manufacturing cars. Instead of doing one car at a time, he developed the assembly line. And so lean's been used in the manufacturing industry for years. It is coming into our healthcare industry and has been for a number of years. And so about 6 or 7 years ago, I took all of the admin team to training for a week to learn about lean, and we came in and we rolled it out to the organization. And to give you a couple of examples is we really started with our supplies. Our supply closets up on the different floors. You used to walk in and you'd have to try to figure out where certain supplies are, so blood supplies versus respiratory therapy supplies. Now they are organized in what's called a smart wall. And so you walk in, they're in color-coded bins. So if you need blood products, they're in red. If you need respiratory therapy stuff, they're in blue. So that way you can go and have it all standardized. You scan everything, so it does two things. One, it tells materials that you use that item, and the second, charges the patient. So that way we can make sure we're restocking and keeping our par levels low because we want to keep it low. When I look at inventory is essentially money on the shelf. And right now we have about $1.7 million of supplies out there. We want to try to keep that as low as we can because we don't want expired products in there. And then the last one is green. From an environmental standpoint, we want to make sure we're recycling and doing our part. And so the green team's been really great on helping us do that. If not, this one is actually outdated. And so I'll talk a little bit about this slide. So we started actually the year with a new position and a new individual, and have not updated the slide yet. But just to kind of walk through it, and I'll talk a little bit about the new position here in a minute. On the orange column is the departments that report to our CFO. So if you look at that, and it is an eye chart for you guys, so we'll see how well you do, is essentially more of the business departments that Danny is over as the CFO. The blue area talks about the departments that Bob Kendrick is our chief nursing officer, and so a lot of the departments that report to him is more of our inpatient units, so our med-surg, our ICU, family birth center, surgery, wound care are reporting to him. Connie Osborne is our chief quality officer, so I mentioned quality a few minutes ago, and Connie's role is to do everything quality related. And then she oversees a few other departments like therapy solutions. She helps with our lean process, clinical nutrition, and diabetes. Team Francetic is our chief information officer and also our privacy and HIPAA officer. And you can see on there that he doesn't just have IT reporting to him. He has respiratory therapy, for example, and lab. And the reason for that is he actually is a respiratory therapist by training and got into the IT side years ago. So we have those departments reporting to him. Dr. Brown is our chief medical officer. So we actually implemented that job almost 2 years ago now. And his role is to really help bridging the gap between administration and our medical staff. Dennis Cockrell is our HR director for a short period of time. He's going to be retiring here at the end of January, and so Allison is going to be our new director. And with those changes, we actually added Scott Nelson as our chief experience officer. And the reason for that is in looking at those customers and looking at where we needed to go for in an organization piece, we really wanted to look at the experience that those three customers are having, and so Scott's going to be heading that up. He is currently our radiology director with STADAT, and so we'll have a lot of job duties in there, but he's been here for a number of years and he's done a great job and he's a great leader through the organization. And then on the right-hand side are the departments that report to me. So Moscow Family Medicine, I work a lot with Moscow Family Medicine on initiatives and what's happening. Risk and our compliance officer report to me. Medical staff, so I deal with all the medical staff piece as either employed medical staff or independent. And marketing along with our hospitalist program and HR. So you see where you report to. That's the only thing you have to do on this one. To talk through just my team and kind of introduce you to them. Connie Osborne is our chief quality officer. Connie has been here for 43 years. Was born here, grew up in Troy, has held various hats in the organization. She's been a director, she's worked in the unit, she's been a CNA, but has held the quality office position now for about 14 years and is doing a great job with that. Danny Linus is also from the area, was born here, and has been here for about 9 years, has been CFO now for almost 2 years.
Year and a half.
We'll round it up. And Danny's doing a great job as CFO, learning all the fun things that a CFO gets to do in there. King Francis, I mentioned, was our Chief Information Officer. King came here as an RT back about 34 years ago. Has been in IT ever since I've been here. I've been here 25 years and is doing a great job on our IT piece. Bob Kendrick is our Chief Nursing Officer, and Bob's been here for about 2 years also. Has a lot of experience, grew up in Shelley, Idaho. You know where Shelley, Idaho is. It's very close to Idaho Falls. Has worked in both sides of healthcare, in the hospital side and consulting. And we were able to hire him away from a hospital down in southeastern Idaho, and he's been up there doing a great job with his experience. Dr. Brown is our Chief Medical Officer. He is a family practice doc by training. Was in family practice for a number of years, left our community and came back and is now working in our emergency department. He's actually has less shifts in there and has been more our CMO, he's half-time CMO, and is working with the medical staff in there. And then I'm going to do something that Scott didn't know I was going to do. I'm going to make him stand up since his picture's not there. So Scott's in the back. So Scott is our new Chief Experience Officer. You will see him later this morning, and I'll talk a little bit about that. I won't have you say anything that you want to say. Yeah, so I want to welcome Scott to the admin team and to his new role that started in there. I have put Scott on the spot a couple of times where I've made him talk. So that is essentially some of the executive team members. With that, I'm going to hand it over to Danny unless you have questions. So one thing we do is at lunchtime, one of the things that we want to try to do is come down here and have lunch with you. So that's why you'll see the extra tables. So we'll be down. So I look forward to seeing you. So far, my schedule is allowing me to get down here. So look forward to getting to know all of you in this new year.
Thank you, Kara. Well, welcome. I see a few faces I've met and a few that I haven't. I want to welcome you to Gretman. As Kara said, I grew up in the area, so I'm a local. Went to the U of I, graduated with my accounting degree, worked for WSU for just a little bit, and then came to Gretman really looking for a place that I could call home. And I found that here. I will have been here almost 10 years. So I'm excited to be here, and I'm excited to work with you guys as you learn and grow within Gretman. So if there's ever any questions I can answer, let me know. I'm going to go over just some high-level financial terms that you might hear from the hospital point of view, so that if you hear them, you kind of have an understanding of what they mean to us as a hospital. And then if you have any questions at any point as we go through this, feel free to ask. So this can be an open conversation if you have questions. So Gretman is a non-for-profit hospital, and not-for-profit is an IRS designation. We're a 501c3 hospital. That doesn't mean we don't want to make a profit, though. So we want to make a profit because we need to be able to reinvest into our entity. So we need to be able to reinvest in capital needs, in wage increases for our employees, to be able to provide benefits for our employees. So that money is reinvested into our entity. We're community owned, essentially. We're governed by a community board, but we don't have shareholders that we have to answer to. And along with being a not-for-profit as a 501c3, as a hospital, we have to fill out a 990 as our tax return. So what that means is we have to show community benefit to the community. So as a non-for-profit, we can't just go out there, make a profit, and then not be doing anything and getting back to our community. There's a lot of ways that we give back to our community. One of the most substantial ways we give back to our community is our financial assistance or charity care policy. So it's posted out on our website. It's also available at any admitting desk and through the financial counselors and patient billing. And so that allows on a sliding fee scale for people to qualify for charity care up to 400% of the poverty guidelines. So it's a pretty rich financial assistance policy for people to be able to come in and have services completed here at Gretna. The other thing, and that usually amounts to about $1.9 million in financial assistance each year to our community. So quite a lot goes back to our community in that way. Other things that we do, we have students through here for many different things. We provide a lot of community support with like fit and fall proof classes, and there's just a wide variety of health fairs that we go to, free discounted blood screens and stuff. So our vision is to be the leading provider of care in our communities and recognized model of quality, service excellence, and fiscal stewardship. So critical access, does anybody know what critical access or CAH or CAH, they're all kind of, they're the same term, just shortened. Does anybody know what that means? It's a Medicare designation, and on the map is how many critical access hospitals are in the United States. Does anybody want to take a stab at how many there are? There's 1,000. What were you going to say?
I was going to say 700.
Close, about 1,348 critical access hospitals in the United States. Probably a little less. There have been some that have closed in the more recent years, but there are quite a number of them. What does critical access mean? That means that we can't have more than 25 inpatient beds. So that includes our swing beds. It does not include our nursery bed, our nursery bassinets. Our average duration of stay has to be under 96 hours. This doesn't mean a patient can't stay longer than 96 hours, but when we admit a patient, the physician has to attest that that patient's going to be out of here within 96 hours. If for some reason there's a circumstance that puts them, when they get in here and they examine the patient and something's found a day later, maybe their pneumonia is worse than what they thought it was and they end up staying longer, that's fine. But 96 hours is what we have to stay underneath. We're finding that our average length of stay hovers around 3 right now. We can't be more than 35 miles away from another hospital. You know much about the area. There's actually 3 other critical access hospitals in our area. So Pullman, 8 miles away, is a critical access hospital. Whitman County in Colfax is a critical access hospital. And then Tri-State in Clarkson, which is right on the cusp of 35 miles, is a critical access hospital. Back in 2004, when we got our critical access status, the state could deem necessary providers that overrode the 35-mile rule, and that's how we got into it. So currently, that's how we're able to get around the 35-mile rule. We also have to have 24-hour emergency care with a physician on call. We actually have a physician in-house 24/7. And what this means to us, because we're a critical access hospital by Medicare, we're paid 101% of our allowable costs from Medicare. So financially, that means that we get a lot of our expenses back because of this on our Medicare patients. So financially, if we didn't have this, it would be a hit between $1 million and $2 million to our bottom line. So financially, it's a very substantial thing for us to be critical access. And it's for rural hospitals, as you see from the stuff. So any questions so far? Boring you guys to death, right? Daily operating costs. How much do you think it costs to run Gretman each day? C? D? C. Okay. Any questions I can answer for you guys? Well, welcome. We're excited to have you. So. Okay. Bob's up next. So he is very entertaining. So I hope you enjoy Bob. I enjoy listening to Bob.
Thank
Pay
you.
close attention.
Okay. You pay her enough, she'll say it. Hi guys, how is everybody? Sorry I wasn't here at the beginning. We're all double booked this morning. So we have the emergency department committee starting at the same time this meeting started. Normally we're here at the beginning and being on introductions and everything, but today we just happen to be on a weird day where we got to be in about 3 different places. Well, I'd like to welcome you all to Gritman Medical Center. I personally love having new employees. I love the new blood. And what I really love is I love fresh eyes taking a look at stuff. I think there's real value in new employees coming into the organization, whether you've been in healthcare before or not, or even if you've been in other businesses or had other positions. I love that you've got the ability to look at something sort of fresh. It does not take long to get used to the way we do things, and that happens quicker than I like to even admit. But I like that you can look at something and go, hey, maybe there's a better way to do that, or what if we did this? Would that be better satisfying to the patient or to the physician or to the, so bring your ideas with you. Try not to lose those fresh eyes too quickly. Our biggest sin as an organization is probably exactly that, our tendency to say, well, that's just the way we do things here, or that's the way we've always done things. Of course, I'm the guy that thinks if somebody ever says, well, that's the way we've always done it here, that right there is probably reason enough to change it up just a little bit and do it differently. So what we ask of you, and what we ask of ourselves, is to be flexible and to be agile. Because my prediction is that 5 years from now, for almost every single one of you in this room, 5 years from now, you're not going to be doing the same thing that you're going to be doing next week. Jobs change, healthcare changes. It's really incredible where healthcare is going. There's a doctor in San Diego, and I was watching his YouTube video the other day, and he was talking about many of the changes in healthcare. And it's amazing. I thought, oh, okay, well, that's way down in San Diego or something. And then I found out that a lot of the stuff that he's talking about is actually even being done right here in our region. It used to be when you needed a new hip or a new knee, and you had to come in and get that surgery from an orthopedic surgeon. You stayed in the hospital for a week and got that new hip or that new knee. They're actually now doing total joint replacement as an outpatient surgery. In other words, you come in early in the morning, and by 4 o'clock in the afternoon, you're back home in your house with a new hip or a new knee. Now, we're not doing that yet here at Gritman. We do total joints. We're not doing that one yet, but I suspect it's only going to be a matter of time. We are doing joints now where you come in on Thursday and get your new joint and make it through the night, and Friday you go home. And so we've literally got it down to where you only stay overnight, and then you go home with a brand new titanium, fancy schmancy joint or something like that. This hit home for me. I don't know how many of you have been in healthcare for any length of time, but when I first got into healthcare, I learned this from my dad. The way we did gallbladder removal. So you got a bad gallbladder and it's got to come. Well, the way we used to do that is essentially we cut you in half with a chainsaw, okay? Folded the 2 halves open, we got in there and fished around until we found that little green gallbladder and we yanked it out of you. And then somehow we managed to sew the 2 halves back together, and you stayed in the hospital anywhere from 7 to 9 days. Well, not too long ago, I guess it's been longer than I like to admit. So I was living in Kansas City, and I grew up in Southeast Idaho. So I called home to talk to I was going to talk to my mom, because at my house, the only person that ever answered the phone was my mother. And they were getting older and everything. And so I'm in Kansas City in my office, and I call home, and my dad answers the phone. I'm like, uh-oh, something's up. Dad never answers the phone. And I said, hey, Dad, how you doing? And he said, well, I think I'm doing better. like, oh crap, there's gotta be a story now. I'm like, well, better than what? He goes, well, I had my gallbladder out this morning. And so I'm like, really? So now when you get your gallbladder out, they bring you in the hospital, they leave the chainsaws out in the shed, they bring you in the hospital, they poke 3 or 4 little tiny holes in you, they fish you in there and find the gallbladder and yank it out. And then you don't even get stitches. They literally put glue on these little holes, all right? Glue or a piece of tape or a Band-Aid. And then a few hours later, you go home. And so just in my, just really in the last 20 years, I noticed in my life, we went from this long 7 to 9 day surgery to now it's maybe a 7-hour stint to have that done. And so healthcare is changing rapidly. They're talking now about intensive care actually being done in the home. That literally home health nurses and doctors and people like that will take care of your needs as an intensive care patient, not in a hospital bed, but you'll be able to stay at your home and have that monitoring and medications and all the interventions and things like that. So healthcare is changing rapidly. There are people getting into healthcare now that blow your mind. I read every day, I read a thing called Becker's Healthcare Review, and it pops up on my screen, and it's an agency that tracks all the changes that are going on in healthcare. And over the past year, all we read every day, there's something about 5 things that Walmart is doing to involve themselves in healthcare. 10 things that Amazon is doing to be involved in healthcare. Yesterday it was, here's the 5 healthcare job openings that Amazon is advertising for right now. And so you've got people out there all the way from the high-tech people like the Googles and the Amazons and people like that, all the way to the Walmarts who are doing unbelievable things in healthcare. Not only are they involving themselves from a business perspective, they're actually trying to change the way healthcare is given to their own employees. And so right now, I know in Georgia, I have a brother that lives down in Augusta, Georgia, and right now in Georgia, to go to the dentist, you go to Walmart. To go to the doctor, you go to Walmart. That literally inside the stores, now you think, wow, is that really happening? It's happening in Moscow, Idaho. Tri-State Hospital in Clarkston now has a little clinic in Rose Hours at the other end of town. And so literally while you're shopping for your milk and eggs and cheese, you can stop by and go to the doctor if you want. And so it's not just happening in faraway places like Georgia, it's happening right in Moscow, Idaho, that healthcare is really changing. So the reason I tell you that is not only don't get way too comfortable just because of the way things are changing, but really be willing to kind of set your mind that, yeah, it's going to change. What I'm doing today isn't going to be the same thing I'm doing 5 years from now. It's just changing. Things are different about healthcare. Now, that being said, I think healthcare is a wonderful career. I think it's a wonderful. For some of you, maybe it's just going to be a part-time job while you're in school and you'll finish and go on to whatever you chose to be. For some of you, it may be a career thing. But healthcare is one of those neat places where every single day, no matter what role you're in, you literally can go home every day from work and know that you helped somebody. You can literally know that I made somebody's burden a little lighter. I cheered somebody up today. I actually helped somebody. For some of you, maybe it's I saved somebody's life today. But that can be done in healthcare, and I've always loved that about my job as a nurse. Is I go home every day knowing that I was able to do some good. Gritman, I'm going to tell you a little bit about Gritman. So Gritman Medical Center is an organization that we suffer under a delusion. Okay, we say we're one thing, but we act like we're something different. And so you just need to understand that. So we're a little critical access hospital. I've been here a little over 2 years, and where I came up from southeast Idaho near Idaho Falls, and we had critical access hospitals down there. One of them was in a little town called, has anybody heard of Arco, Idaho? Anybody know what Arco's famous for? It was the very first city on this entire planet that was lit and powered by nuclear power. That's little Arco, Idaho. Well, they have a hospital in Arco, Idaho called Lost Rivers Medical Center. I love this medical center. Their average daily census is 1.2. So they've got a whole hospital out in this little town that on average every day there's one patient in the hospital, one inpatient. Now they do a lot of outpatient stuff and some other things. They have a little emergency department. Of course, when you go into that emergency department, they have to call the doctor at home. They have him come in and take a look in order to come take a look at you. But they literally have 1.2 patients, and they just do just a few things. And I'm not even sure they do them great. I don't, it's just, how do you keep a hospital open with 1.2 patients? Well, we're a 25-bed hospital. I'm going to tell you that that's kind of a misnomer because we act and we think like we're a 200-bed hospital. We do unbelievable stuff here. We do lots of things that little critical access hospitals typically don't do. We have lots of specialties, which I'll introduce to you here in a second, and we have lots of services that you're just not going to see in your average critical access hospital. So while we say, yeah, we're a 25-bed critical access hospital, we don't act like it. I took this job thinking, oh, man, I'm kind of on the tail end of my career. I've worked in university medical centers and level 1 trauma centers, and I took this job thinking, I'm going to be able to kind of kick back to the last couple of years of my career and just take it easy and then slide on out. Oh my gosh, I could not have been more wrong. I found out that in all those other hospitals, those bigger hospitals, there's somebody to do everything. There isn't somebody to do everything here. We literally have to be comfortable with sort of being jacks of all trades. Hopefully we'll master a few, but, and I say that, just, be a great team player while you're here, be willing to help out, regardless of who needs your help or obviously don't do anything that you're just not qualified to do and would put you or a patient or something like that in jeopardy, but don't ever be afraid to help out, particularly if it's the right thing to do, for a patient or a patient's family or a dog. You've kind of already seen this little thing. I think Kara probably showed you that, and so we're going to go right through this. It's real busy anyway, and I think we're in the process of sort of changing this whole thing. But I won't go through all these, but I'll give you some examples of things that we do. We run all the way from a hospital. We have an emergency department with a physician on board, 24, many of them board certified emergency physicians. They're here 24 hours a day, 7 days a week, all year round, every single day. So that's pretty typical. We've got an inpatient unit, a medical and a surgical unit, inpatient. We've got an intensive care unit. We've got what we call our family birth center, where people come in to have babies and expand the size of their families and all that sort of business. We've got we do swing bed, which for people that don't need acute care in a hospital but aren't ready to go home, let's say after a surgery, we've got a swing bed program where they can come in and it's almost like a skilled nursing facility. And that's up on our med-surg floor. We have all kinds of diagnostic testing and very, very sophisticated, obviously expensive equipment that we do things with. Little critical access hospital we do. Does anybody know what hyperbarics are? Okay, a hyperbaric chamber is this weird space-looking coffin-shaped thing that you shove people in and you literally lower the atmosphere, or you increase the atmospheric pressure, and you force oxygen into their tissue. And so for wound care patients, for diabetics, for carbon monoxide poisoning, for gangrene, for a number of things, we actually have a wound care center, which most critical access hospitals don't have. But we take patients in, and it's literally called taking them on a dive, or diving the patient. And so you put the patient in there, and down they go. And it's literally measured in feet below sea level and all that kind of business. So it's like going on a submarine. And you have to be careful. You can't bring them back out of that too quickly, or guess what they get? They get the beds, of all things. And there's no water involved, so it's kind of cool. Well, we don't just have one hyperbaric chamber. We have two. Got a great big one for great big people and a smaller one for smaller people. So But literally, most critical access hospitals don't have those kinds of things. Obviously, full lab, pharmacy, big surgery department where we do both inpatient surgeries and lots of outpatient procedures, lots of scopes. We are the majority partner in an ambulatory surgical center, which is up by Walmart, up there, whatever direction that is. We do, I don't know, I think we did like 2,100 surgical procedures up there last year. So we do all kinds of surgical procedures there. We range, and so we do all that right here in Moscow. Out in a number of rural clinics, we have, rural communities, we have clinics. And so in the communities of Troy, which is 10 miles that way, and how far is Potlatch? 15 miles to Potlatch, and then Kendrick, a town that they named after me when I moved here. I moved here, and I don't think so. My wife and I, we truck, I grew up in southeast Idaho, in a little town called Shelley. Anybody know what Shelley, anybody know about Shelley? What's it famous for? Our high school mascot is the second best mascot, maybe in the whole world. We're a potato. We're the Shelley Russet potatoes. We're not the Knights or the Cougars or the Hawks or the Eagles or anything like that. We're a potato. That's awesome. That's not as good as Orofino. Anybody know what the mascot is? The Maniacs. There's a mental hospital in Orofino. That's the one that I'm like, that's gutsy. Maniacs. That's awesome.
That's Orofino though.
Okay, that's gutsy. I like Orofino. So they're the Orofino Maniacs. I think that's the best high school mascot of all time. And second is potatoes, Shelley, Idaho. So anyway, grew up down that way, and I'd always heard of this town, Kendrick, and of course my last name is Kendrick, and so I thought, well, we moved up here, I gotta go see Kendrick. We went there, and there's a Kendrick clinic, and then there's a building with Kendrick on the sides, and there's a Kendrick swimming pool, and the Kendrick fire department, and there's about 10 or 12 different things with Kendrick High School. And I've probably got my picture by every single one of those signs. And I immediately put it on Facebook, and I also sent it to all my friends going, I've made quite an impact up here. So if you're good at what you do, they'll name a town after you. Didn't go very far, but anyway. We've got a clinic out there. We've got some clinics also here in town. We have psychiatric services, we have neurology, we now have cancer services. We've got a board certified oncologist, we've got an infusion center, we're doing all of the chemotherapy for cancer patients. It just goes on and on. This is not an exhaustive list, but we got all kinds of things. As an employee, we've even got a massage therapy department, so if you really get stressed, you can go get a massage if you want. So we just do lots of stuff here that you typically wouldn't see in a small place. And what I thought was going to be a real easy job has turned out to keep me pretty darn busy. Now, I'd like to quickly talk about, this is probably one of the only things I would tell you even need to think about remembering, is kind of the way we do things, and at least the culture that we're trying not only to maintain, but to build on and to evolve and enhance. We're trying to make that culture better. And so we Kara probably talked to you about this thing called the Gritman Way. Well, what is that? Now, for a lot of us, these steps will kind of help explain that, or at least you can kind of focus on them a little bit. You look and say, well, okay, a clean and safe environment. That's pretty. You cannot believe how who in here's had surgery? Anybody had surgery? Okay. For any of you that had surgery, how good was the surgery? How'd they do? You act like you don't know.
I was under anesthesia.
Oh, so you don't know? You have no idea, right? I'm alive. Yeah, I'm alive. I had my, not to tell you too much, but last year I had my prostate removed. And all I know is that, I don't really even know if it's gone. I know I can pee better, so that's okay. And the doctor said he took it out, but I'm like you. I don't know how he did. I don't know how many times he's down in there and he's taking stuff out? I don't know if there were any of those moments when he went, oh crap, shouldn't have done that. I don't know. And so how do I judge healthcare? Well, you can't believe how many people will judge their entire healthcare experience on something like cleanliness. In other words, they don't know how good the surgery was. And now they'll judge their healthcare experience on how good breakfast was, or on how clean their room was. Or if the room wasn't clean, then that basically colors the entire experience for them. So I was working in the intensive care unit down at Eastern Idaho Regional in Idaho Falls. I'm an intensive care nurse. And we had a patient, and we actually saved the guy's life. The guy came in and he was septic, which means he's got this massive systemic infection that is shutting him down quickly and is going to kill him. So we do all the things for about 3 weeks. This guy is completely unconscious. He's intubated. I took care of him many, many nights. We're giving him all these kinds of really heavy antibiotics, and we're keeping his blood pressure up with medications, and we're doing all these things to try and cure this guy. And ultimately, we cured him. Now, we probably spent $200,000 keeping this guy alive, but he walked out. I mean, he got better after 3 weeks in the ICU. He went up to the floor for about a week, and then he was discharged from the hospital after about a month's stay in the hospital with this terrible sepsis. His wife did not want to pay the bill, any of the bill, their portion. I mean, I think he was, I can't remember what kind of insurance he had, but obviously there's a little piece that's left, and she didn't want to pay it. And you're going to love why she didn't want to pay it. Because one day in those 25 days or whatever that he was in the hospital, you're not going to believe this story. Didn't want to pay the bill because one day there was a dead fly in the windowsill of the hospital room. So one day they're in there, they look over in the windowsill, there's a dead fly. Now, housekeeping cleaned it up, gave it a nice little burial or whatever they do with dead flies. But she said, no, the room was filthy. And I had the opportunity to meet with her. And honestly, it was like, well, how on earth can that happen? And I'm like, I don't know, came in with you. You open the window, I don't know. But it was just amazing. And we deal with that all the time where we'll have somebody that's not happy with their health care, and you'll get down to something as simple as that they didn't feel like it was clean. And so I shouldn't have to pay for the life-saving surgery that you gave me because something was dirty in the room. And so for any of you if you're in environmental services, that's how important cleanliness is because for some of us, for some of our patients, that's the way they and their families judge their health care. We also have got a lot of, and so it's really important that we stay clean and we do things clean and all that. Safety is super, super important. We have patients that they're very most vulnerable, and they literally trust us. They literally turn themselves and their bodies and their health care over to us, and they trust that, hey, that medication that you're giving me is the medication I'm supposed to get, and it's the right dose, and you're giving it at the right time, and all those kinds of things. And so we have safety things put in place. Don't ever bypass those. If we have a patient, for example, that is a 2-person lift or a 2-person assist, unless it is a dire emergency and there's blood spurting out of somewhere or something, don't ever do it alone. They're a 2-person assist for a reason. And that's obviously first and foremost for their safety, but frankly, it's for your safety as well. And so you're going to see all these safety measures that we have here in healthcare, and they're designed first and foremost to keep our patients safe, but they're also designed to keep you safe. And so understand that people judge their healthcare on something just as simple as that. The second thing, we want to be known as caring and compassionate, and we want to give great service. Now, we have competitors very close by. We've got 2 hospitals down in the Lewiston Valley that are competitors. We've got Pullman over that direction. We're very, you talk about competition. Right now, Walmart, if you're a Walmart employee here in Moscow, Idaho, and you hurt your back to the extent that you need back surgery, guess where you get that back surgery done? Anybody know? One of 5 places in the United States. So what Walmart has done is they've gone out and they've looked at, well, who does the very best back surgeries, has the very best outcomes, and does it for the very best cost. And they will literally put an employee on an airplane and send them to Minnesota or send them to Arizona or send them to Texas or to Florida to have their back surgery rather than having it done here locally. That's how much healthcare is changing. I was on a plane about 2 years ago, sitting next to a man and his wife coming from Los Angeles, and we were flying from Los Angeles into Salt Lake City. I got talking with them, and what I discovered is he'd actually been over in Thailand to have his coronary artery bypass surgery. In other words, he'd gone to Thailand to have heart surgery, and then he told me the thing that just blew my mind. He said, oh yeah, the insurance company paid for all of it. The insurance company paid for my flight, they paid for our hotel, they paid for my surgery, they're paying for all my drugs. And so 10 days ago, I had my chest opened up and they bypassed 4 vessels, and now I'm on my way back home. There's like 5 hospitals in Salt Lake City that do bypass surgery. And yet his insurance company was willing to fly him all the way to Thailand to do that. And so the way transportation is these days, and the way these companies like the Walmarts of the world are doing things, we have to differentiate ourselves somehow. Now, do any of you think we can buy better equipment than they can over at Pullman? In fact, when we buy something new and cool, we always know that within 2 weeks, Pullman's going to buy the same thing. Or if we find out they buy something really cool, guess what? Within 2 weeks, we buy it. And we buy it from the same salesman. That's the thing that's, so we don't have the ability, nor do we have enough money to buy better equipment than anybody else. So how do we differentiate ourselves? And the way we do that is we do that through you, through our employees. We show compassion. We do things that other people won't do. We try to make sure that we never inconvenience our employees. We inconvenience the heck out of ourselves, but we do it for our patients, okay? So anytime you've got the choice between inconveniencing yourself or inconveniencing the patient, always make your own life miserable first before you involve the patient, okay? We've got some really cool things that have happened before. We had a just to give you an example, out of the box, not on a job description. We had a couple of members of our nursing staff up on our med-surg floor that a little over a year ago, we had a patient that came in. She had to stay in the hospital. The little old lady had to stay in the hospital for a few days. She had one worry, and it ate her up. It ate her alive. She had one worry. Guess what she had at home? A dog. And she was so concerned about the dog. Well, guess what? There's nowhere on the job description where you're going to see that your job is to take care of the patient's dog. And yet we had 2 members of our nursing staff that went in the morning and fed the dog and walked the dog and bathroomed the dog and all that kind of business. On their lunch break, they'd run to her house, make sure the dog was okay. At night, they ran over there, they fed the dog, watered the dog, did all that. And they of course, with cell phones and all that, they brought back pictures of the dog and little videos to show the patient. And look, Fluffy's doing great. And we played for 15 minutes and got Fluffy some exercise, and we'll see her again tonight. Guess what? That made an unbelievable difference in the life of that patient. Not in a job description, but it showed compassion in a way that was completely unexpected by that patient. And so those are the kinds of things we love to do here at Brittman, and that's how we can differentiate ourselves and make ourselves better than the guy next door, whoever that is. We want to be consistently excellent at what we do clinically. And so we, unashamedly, we will steal any good idea. We'll steal it and implement it if it's better than the way we're doing it. Whether that's how we give service, whether that's the way we do something clinically. We try to stay in touch with the latest evidence and science out there in terms of how things are done. And what that means, again, I'm going to go back to you guys, it means flexibility on your parts. Because sometimes somebody's going to come back from a conference or somebody's going to figure something out, and it's going to be a better way of doing something. Sometimes that's going to rock your world just a little bit. It's like, well, wait, it's not the way I was trained, or wait, that's not the way we do it here in Moscow. And if there's a better way to do it, every single one of us really has the obligation to figure out how to do it better, how to do it differently, how to make that difference. And so we want to be excellent at what we do. Communicate the heck out of stuff. Anybody in here, okay, I'm going to use a term. Let's see. How many of you, is there anybody in here who does, oh, actually, that's not there. How many of you know what the term hypertension means? Hypertension. There's some of you that don't. Now, inside the hospital, we use a term like hypertension, just like, well, it's just a normal word. Okay, for those of you that know, what does hypertension mean? What is it?
High blood pressure.
High blood pressure. Explain to me why we can't say the words high blood pressure. And yet we'll talk to a family, you know, that came in from Kendrick, their relatives. They come in from Kendrick and we'll talk to them in terms like that. And the easiest word we'll use is something called hypertension. And then we kind of look at them like, well, why don't you understand what I'm saying to you? And so we've got to be willing to communicate in a language that our patients and their families can understand. And so you think, well, it's kind of dumb, but instead of saying what we're used to, hypertension, we need to say you've got high blood pressure. And by the way, that's just the tip of the iceberg. There's all kinds of terms that we use, and we've got to be willing to talk to people in a language that they understand. And we've got to talk to them before they get to the hospital. We talk to them while they're here. After we're done talking to them, we talk to them some more. When they go home, we call them and talk to them. We just got to communicate the heck out of things. That's one of the biggest complaints that we get is, well, nobody told me that. And so we don't want any of our patients or their families to ever say to us, well, nobody told us that. So anyway, communicate like crazy. Collaboration, we kind of talked about, you know, jumping in and helping wherever you can. We just, so we've got one person in this hospital that's over risk management. I called the University of Utah to try and put this new risk manager of ours in touch with the University of Utah's risk manager. I used to work at the University of Utah. And the answer I got was, well, which person in risk management do you want? And I said, well, you know, your person that does risk management. And they said, well, that's a lot of people. And I said, well, how many people could that possibly be? Well, they're in 2 different departments, and there's 40 people that work in risk management at the University of Utah. We have 1, okay? And so we've got to collaborate. We've got to help each other. We've got to be able to jump in and do things that we're a little uncomfortable with sometimes. And again, don't do anything that you're not qualified to do or that puts you or the patient at risk, but be willing when somebody needs a hand to jump in and help them out. And then, like I said, we talk to them before they get here. We talk to them while they're here. After they go home, we talk to them. And but that's part of what the Gritman way is. That's how we try to differentiate ourselves and make ourselves special, and make sure that people feel comfortable coming here. And if they ever have to come back, heaven forbid, they know where to come back to, and that keeps all of us employed, which is awesome. So the Gritman way, it's about how we give service. It's all about the patient. Remember, you ever have a choice between inconveniencing yourself or inconveniencing the patient? Make your own life miserable first, okay? Clinical excellence, we want to do it the very best, safest, most up-to-date way that we can possibly do it. And we do that through our employees. And so you'll find that we've kind of got these 3 customers, and we think that one of them is each other. And so we try to make your lives, we try to make our lives good. We want you to enjoy your work here. We want you to be fulfilled by it. I want every one of you to be able to go home every day sort of feeling like, hey, I helped somebody today. I lightened somebody's load today. Some days it'll be, I saved somebody's life today. So every patient, every time. Everybody remember back in school when you got 97% on a test, what letter grade did that get you? It was an A. Guess what 97% gets you in a hospital? Only 3 dead people out of every 100, okay? So we literally, this is our goal. We do it right with every single patient, every single time. And we try to hardwire those processes that'll make sure that'll happen. To the 97, that's okay. It's kind of a big deal to the 3 that we get it right, you know, more than 97% of the time. Here's some things that we do that we try to do always, just as a reminder, and I'll just point out a couple of them. Always make sure that you're talking to who you think you're talking to. Okay, and verify they've all got name bands. Make sure that you're talking to the patient that you think you're talking to. We always verify what we're doing and make sure that patients understand it. Do not be afraid to wash your hands, and after you've washed your hands, wash them again. And then 5 minutes later, you know what you should do? Wash your hands. And that protects not only our patients, but it protects you. I don't know if you know this, but hospitals where sick people come. And so protect yourself. Wash, wash, wash. Keywords at key times. Please, thank you. What do we say when we mess up and we fail to meet somebody's expectations? What's your what? You say sorry. Isn't that an admission of guilt? It is not. That's right, it's not. When we mess up or when we fail to meet somebody's expectations, we apologize. I'm sorry, we'll do better this next time. Whatever it is, that's what we do. We try to, individualized patient care is kind of an interesting one. We have those patients that want to talk to every single employee in our hospital and find out everything about you. And then we have people like me that please close the door and leave me alone and let me die in silence. And so we've got to, it's our job to figure out, well, which one is this patient? Is this a chatty Cathy or is this a grumpy Bob? And what's the very best way for me to deal with them? Whether that's, and we do that with care, we do that in the way we communicate. We try to see our patients hourly. Every hour we want to be in those patients' rooms to see those patients. We found out when they do that, they don't have to press their call line as often. They don't fall down as often. Patients fall a lot in hospitals. Do you know why? Why would patients fall down in hospitals?
They're sick.
Okay, they're sick, so they're not feeling very good. They're dizzy and woozy and weak, and so they're sick. What else? What else causes people to fall down? Okay, sure, yeah. Yeah, different little ledges and stepping into the showers and going into the bathroom and I don't know if you noticed, but lots of patients in hospitals have lines stuck into them. They trip over their IV lines. They've got poles and pumps and lines and everything else. Let me tell you one of the other reasons patients fall. They fall because they don't want to bother you. And so I literally picked people up, little old people up off the floor, like, what are you doing on the floor? Well, I didn't want to bother you. It's the middle of the night. I'm like, I'm getting paid to be bothered. You call me. Don't fall down. You know, that's craziness. Don't do that again. So people fall down a lot in hospitals. We found out that when we round on them hourly and see them hourly, they fall a lot less and get hurt a lot less. You'll see people like Connie's going to talk to you next. You'll see she and I going into patients' rooms, and we like to go in and talk to the patients and find out how's it going, what can we do better. And so we have lots of different ways to get that feedback from our patients. And like I said, and when we blow it, when we don't do it right, or we make a mistake, we own up to it, and we do it better the next time. Okay, that's it. Welcome to Gritman. It's really a great place. I've been here for a little over 2 years, and it's been just about as much fun as I've ever had in healthcare. I'm as busy as I've ever been, I can tell you that. I've done more things and more diverse things than I've ever had to do at any other hospital. So it's a fun organization. Enjoy it, bring your ideas to us, keep those fresh eyes. Now, any questions? I'm just going to warn you, I don't care how stupid the question is, and everybody says there's no such thing as stupid questions. I've asked a few, trust me. I don't care how bad the question is, I never leave until I get at least one question on something, on anything. One question.
Do you know what patients prefer as far as the food? Is there any food that patients have remarked on?
Generally speaking, that's a good question. Generally speaking, here at Gritman, they compliment the food. The food's pretty good here. I'll warn you all right now. Did anybody warn you about well, some call it the Gritman 50, some call it the Gritman 20, I call it the Gritman 15. Two people in this organization can't meet without there being a meal involved somehow. There's food in everything. And so watch your waistlines. It's real easy to put weight on here. Generally speaking, the food's good. Sick people don't do really well with real fatty stuff, you know, and so fresh things are, I think, important to a lot of people. For me, I was in the hospital and had this surgery. The best thing I had the whole time I was there were hash browns. I don't know. I mean, I don't know. It's a good question. I'll tell you. Any other questions, folks? Okay, Connie Osborne is our Chief Quality Officer. She's probably going to send down a little break.
Yeah, well, how about we take like a 5-minute break, because I know it's a long time to sit, so.
Such a year.
Use the restroom, warm up, get hot tea, coffee, this room is cold. We'll be back in 5 minutes.
Thanks, guys. Welcome.
Dave, how are you? This morning.
Somebody told me that. Somebody told me that. Bottom idea. I don't know.
He wasn't from Denver. He wasn't from Denver.
Oh, when I was working in the hospital in Dayton, Ohio, and my name was Robert L. Kendrick. When I was not from there.
All of our formula, she had an ear infection. When I was taking the diseases. She was kind of close to the bit, and we were trying pretty soon to surprise me. She has an infection.
I say that's not
It's all better. Okay. Anyway, I don't
Somebody told me about the trading.
Yeah.
Anyway.
You know, that's how it goes.
You gotta work harder than that. Yeah, you gotta work harder than that. Might as well start out. I've been out there. Yeah. Oh, so I don't know. I've never been. Oh, great. Yeah, I think it worked too. Try hard. Try hard. All right. See ya. See you.
I hear we're supposed to have 10 inches of snow by this Saturday night.
Oh my goodness.
That's what somebody just told me in the hall. I was like, what? We'll be out of the car and eat. Yeah, I heard that. And then not heard about the party Saturday night.
It's gonna be locked in, sounds like.
It's gonna be fun. The parties are always fun. Just come in your 20s gear or not. You don't have to. Gotta love this room. It used to be the old laundry room. So in the back there were these huge, like 7-foot diameter washer dryers and tables to hold all the linen on. And yeah, now we obviously contract out on that and move this, but you cannot, it just goes up and down. I'm looking at, so Skylar, what clinic are you gonna be working in?
In Potlatch.
In Potlatch, awesome.
Yeah. Yep.
That is so cool.
Yeah.
It's a fun place.
Yeah.
Jimmy's already in. How long have you been over in Jimmy? 4 weeks. Wow, good. That was good talk, yeah. No. I'm kind of a rowdy one. Childcare, and I get sleep. Sorry.
Yes.
Yes, awesome. I'm ready to Ready to always come to it. Okay, we'll get started here. So I'm Connie Osborne. I'm the Chief Quality Officer and Joint Commission Coordinator for Griffin. I am a nurse by training, and I have been at Griffin for 43 years. So don't do the math. You can figure that out later. So I actually was born at Griffin. Grew up in Troy, married a farmer. You don't move a farm. So I've been here ever since. I think I've worked in every nursing department of the hospital. I do like to converse with my patients, so surgery wasn't much fun. And Family Birth Center is like after having twins, I thought that department was cursed, so I didn't go back. And so most of my career, about 17, 20 years, was in intensive care unit. So that was my big love. Got certified in intensive care, took the 4-hour exam way back in the day. Passed and stayed certified for a while. Did stress tests and all those fun things. And working in ICU. And then back in 2006 is when this whole chief quality officer position came open. And I thought, oh, well, that's intriguing. And at the same time, the Joint Commission coordinator for the facility was also retiring and transitioning. So they combined the two positions, and I applied and actually got the position. And maybe just to give you a little history, I like to create things. So one of the things that back in 1998, 99, I wrote a federal grant to start our cardiac rehab program. And then that grant was a 3-year grant, and we actually started with 1 treadmill and 1 bike in our spare room in ICU at the time, and started our cardiac rehab program. Well, it quickly grew, and we were in a room next to administration offices for quite a while. And then when we built the new medical office building, they were able to move because, again, the size and volumes of patients that we're seeing now is just going crazy. I think our high day, I don't know, was like 76 visits in a day now over there. Monday, Wednesday, and Friday for cardiac. Tuesdays and Thursdays, they do osteoporosis. They got them living over there cooking iron. Pulmonary rehab. So that's kind of one of my babies I've had for a while, and they're one of the departments that now report to me. So as Kara showed you on the slides, I have a number of departments that report to me. Pharmacy, therapies reports to me, but also being the Joint Commission coordinator for the facility, I get to see everyone because we visit every department at least once a year if you're non-clinical. If you're a clinical department, we come by every 2 years. And when I say we, it's the infection prevention nurse, it's me as the Joint Commission standards, it's EDS, so Jonathan is our director of EDS, he's coming through with us. Dennis Nihinki, the director of our facilities, coming through. Derek Snyder, who's our safety officer for life safety and fire prevention, all those things. They join our group, and then we also have Anna, who is our risk and compliance person. So you get this entourage of people that converge on that department, usually unannounced. And we are looking for those things that we need to improve. And those can be as simple as outdates that we find on hand sanitizer, or maybe people bring in their own sanitizer or lotions, which is a no-no. And that would be like, well, why would that be? Well, hospitals, because of the infections and the patients that have potential infectious diseases that can be communicated to another patient or even a worker, means that we have to have certain products that we know are at a level that can kill the virus, the bacteria, and all those things. So the hand hygiene items that we have in the hospital have been approved by the products committee, which is headed up by Dr. Grindelman, who is our pathologist. So these are all been tested, approved, and to even brag on EVS, and I said I was going to do this, You know, it takes a whole group of people to keep a low infection rate for a hospital. So nationwide, there's different indicators. So hospital-acquired infections. So that could be pneumonias from the breathing tubes when people are on ventilators. That could be from central lines or IVs that we put into big veins to help patients with some of these medications. But they actually are sources of infections if you don't treat them correctly. You can have surgical site infections. You can have infections occur from Foley catheters being put in or left in too long. So we track all of that and we make sure that we have as low as infection rate as possible. So nationwide, the infection rate for hospital-acquired infections is 3.5. So anybody knows what ours is? It's 0.2. And I'm bragging, because if it wasn't for EDS going in and cleaning high-touch surfaces, everybody's doing their part in hand sanitizing, prepping patients for surgery, we wouldn't see those numbers. And in fact, we have hospitals calling us to ask what we do. So one of the things that we did, which is really cool, and I have to tell you what we did. So there is a product, and it doesn't have to be, the brand name's Nosen, but we started a trial a couple of years ago. And what we found is that if we use Nosen, all it is it's a alcohol-based that has a citrus aroma to it. And we actually have patients use that. It's 3 wipes in your nose, one theirs and 3 in the other. And we do that before surgery. And then we do it every 12 hours after surgery. And we have seen like no surgical side effects. Because what do people do? They touch their nose, they touch their face, and then they touch another surface. Interesting. So we also have up on Med-Surg, we have a UV box, and we encourage all the doctors and nurses and anybody that's around you in there. You can put your cell phones, you can put your keys, you can put your name badges, you can put blood pressure cuffs and all that, and you can sanitize it by UV light, and it kills all the bacteria and viruses. So obviously, we're very committed to making sure our patients are safe and none of those infections. So I'm just going to kind of go through a few slides and talk about quality and why is it important. So I start with in or out. I like food, and I eat. I'm kind of one of those people. So let's say who's the newest to the community? Who's actually just moved here not too long ago? Skylar. Right? Yeah. So some of us that have been here forever. There's been like this new plethora of restaurants in the last 5 years or 8 years or so, and actually some nice, really good ones. And so we've got this restaurants where it's a nice sit down, you know, you can go in and have a nice steak, all sorts of things. So let's say we're all gonna go to this new restaurant. They just newly opened, we're excited, we've heard the food's good, so go in there and we're sitting down for dinner. The service is slow. In fact, they're kind of rude. But when we get the food is awesome. Food is great. In that example, how many, by show of the hands, would go back to the restaurant again? Yeah, real. If they got good food, you can put up with some not so good service. Now we go back a second time. The service is a little better. Food's still awesome. Would you go back a third time? Show of hands. How many would say something? How many would run? Yeah. See, it's really interesting because even like I've been asking this for a couple, 3 years just to see the mix, and about a third. So if you start, some will like, they've had their chance, I'm gone. You know, the second's like, well, we'll give them a second chance, but the third chance, it's like, people now are saying something. Yeah, and who's been surveying, getting all sorts of surveys? You buy a car, you get a survey. You buy a product, you get a survey. You get surveyed by AT&T and Google and everybody else. You know, they're sending surveys. You answer them? Yeah, sometimes, right? When it's not good service or good service? Only when it's bad service. See, those are the things we remember, right? Do you ever remember having, like, think about when you've gone out to dinner and you've had an awesome evening. It's the atmosphere of the restaurant, it's the food of the restaurant, it's the waiters, waitresses of the restaurant. I mean, they make that whole experience fun, right? You know, when you're having a good time and everybody's having, you leave and it's like, that was great. Now, you know, we don't expect people that come into the hospital, unless you're gonna come in and have a baby, because that's a happy vacation. But mostly people are coming in because they didn't quite plan come in to have to seek health care. You know, you're either here for a drug test because you're needed for your DOT license, or maybe you're here because you don't feel so good and now you have lab work that they're doing. Maybe they're doing x-rays, find that, they did find a spot on your mammogram, and now you're having more testing. Now maybe you're having surgery because you did a oops. We have a very populace of four-wheelers. So when people are out using their four-wheelers, we can pretty much guarantee we're gonna have a major four-wheeler accident about once a month. When I say major, it's more than one issue. They have fractures, they've got collapsed lungs, they've got lacerated livers or spleens or something's going on. So we have major traumas that come in here at least once a month. And then of course we get our heart attacks and pneumonias and all that good stuff. But when you think about people having a choice, if you have a choice of where you're gonna go, or where you have a choice of buying a car, or where you have a choice in who you're gonna select for your health care, you're really expecting the quality to be there, right? Because when you're buying a new car, you're like, oh, you expect the motor to run, the brakes to work, the windows to roll down. But when you're buying a car, what are you buying? You know, I look for color, I want to make sure there's lots of cup holders for my coffee, you know. But when you think about it, the expectation is, if you come into any facility, particularly a hospital, that it's going to be safe. That you're going to get the right medicine, the right treatment, the right surgery. But if you read the headlines in Facebook, some people use for their news, you know, there's things that happen. The wrong kidney being removed, the wrong leg amputated, the wrong medication being given. Why does those things happen? And I don't know anybody that goes into healthcare that goes, oh, I'm going to do a bad job today. I'm going to harm somebody. Now, no, you know, I went into nursing because it was like one of those things I always wanted to do. I always wanted to be a nurse. I wanted to help people. I mean, I've defibrillated people, I put tubes into people, I've done all sorts of things. And the majority make it in. That was great. There was a few that did it. And then you mourn with their family and you hold their hand and you do what you can. So when you think about that experience, whether it's not a good outcome, or it's a great outcome because there's a healthy, breathing, happy baby, you know, the purpose of that quality, what people take away from that, is how they were treated. What makes you go back to any restaurant? What makes you go back to, you know, whether it's the good food, it's how you're treated. You know, if you have somebody that you're walking up to the front desk, let's say, even at Britain, you come in through the front door, if you don't have somebody that's up, gives you eye contact, even recognizes that you're there. Have you ever been in a line and the person hardly looks up at you? Yeah, you know, you feel real valued, right? So that's what's different about Britain. Because when you think about the Britain movement, so far as our culture, it is that we care. We truly care. And like Bob gave the emphasis, we've had weddings in our ICU because grandma or grandpa couldn't make it to the wedding. So they actually, the couple was come and redid their vows in front of them. So that's pretty cool. I mean, I've taken care, you know, came upon an accident. The ambulance was there, they were helping the individual was concerned about their dog, and the dog was obviously in the truck with that got rolled over. I took the dog to the nearest vet and made sure that everything was okay, and gave that to the patient so they knew how their dog was doing and where the family could pick up the dog. So it's just things like that, you know, we take care of each other, we're family, neighbors, and friends. I mean, I probably am related to pretty much everybody in Utah County one way or the other. But again, when we talk about quality, we're talking about how people can feel well taken care of, that they don't have to worry about who is this. And I can tell you some stories on quality care. So who's responsible for quality? What is it? What and where? And we'll talk about all that stuff. So when Kara talked about that nice volunteer board, they're ultimately responsible for the quality care we give here in our institution and all of our clinics and all of our outlying departments. So that nice volunteer board wants to make sure they have the data and the knowledge of what's happening in all these departments, that we are giving good care. And that's part of my job within quality, is to provide that data. And then administrators, obviously those chiefs that Kara talked about in that organizational chart, we're responsible to keep track of our departments, make sure we're getting quality care. Physicians, we have a number of physicians that are contracted, if not employed by us. They have to go through a strenuous credentialing process to even make it through the doors to give care in an office that we have here or by a surgeon or anything. They have to be credentialed to have privileges here. And that's not an easy process. And then we have staff, obviously, and students don't get off the hook because we have a number of nursing students, radiology students, lab students, and first year and second year, Wyoming, Alaska, Montana, and Idaho med students from the University of Washington. They're here. So we want to be that example of what is that good example for all students of how people should be cared for and what they should expect within an organization. Okay, so who should receive quality care? Obviously, everyone. It doesn't matter where you have the ability to pay or not. They can come to any of our clinics and request care. They can come in to the ED and request care, and we don't ask if they can pay for it. We don't ask for insurances. We ask what is it that you need to be seen for, and then we triage them, and we get them started in the process of getting seen. And that's part of being a 501c3 or not-for-profit. We do provide care. We have a good number of patients that can't pay, that are on payment plans if they need it. But healthcare is expensive. You know, but we take for granted because we work in a facility that has healthcare for employees. You know, one of our for full-time employees, I think it's half-time employees, one of the benefits is having LifeFlight membership. It's like $79 a year, but a trip in a helicopter is now around, I think, $27,000 to $30,000. You know, so you have the expertise of all those people in that helicopter, plus flying that helicopter and the expertise of that, which you want to make sure that pilot lives. But again, you know, it's expensive. So back in 1999, there was a report that the government had done through the Institute of Medicine that showed up to 98,000 people died annually in hospitals due to errors that could have been prevented. That's a horrible number. And then Medicare and Medicaid, being the highest payers of that care, were costing at a $29 billion a year back in that time. That's quite a while ago. So has quality improved? Yes. Has it improved as much as we want it to? No. You know, we don't want anything to happen. But errors are caused by faulty system conditions and processes. It's not that anybody, you know, there are a few of those that, you know, purposely go out to harm, which, you know, get into the jail system and all those kind of things. But again, you're not looking at, you know, a nurse didn't mean to omit a medication or miss a physician's order or something along that. Okay, so one of the things that Medicare and Medicaid did, Centers of Medicare and Medicaid, so CMS, they wanted feedback from patients. Because the only way that you're going to get improvement, just like restaurants and your Ford dealer and all those, they want to know how they did in providing that service. So Medicare and Medicaid came up with a standard survey, and every hospital across the nation is required to do this survey. They cannot like for us, we cannot hand it out in paper form. We can't do any of those things. It really has to be through a vendor that is done in a way either by phone or by mail so that the patient feels comfortable providing that information. So I want to go through the questions and kind of get your guys' ideas of what you think that is. So they call them domains, but there's 3 questions about nurse communications, 3 questions about doctors, and on down. So we'll kind of go through that. So right now, who's worked already in the hospital, has been around, seen people? Yeah. Do you know who the nurses are? How do you know who's a nurse? The badge. Right, there's a little thing, which I don't have, I should have, but there's a little thing that hangs down that says RN. Because back in my day, we wore hats. I became wearing a hat to work. And then we wore white uniforms. The whole thing had to be white. We wore white, that was what nurses wore. Well, now everybody wears scrubs, colored scrubs, everything else. They don't wear their hats anymore, maybe except on nurses' day. How do you identify? So again, that badge is the only way that sometimes you'll know who a nurse is. Interesting study done. If you come into a facility as a hospital and you're treated, they've done studies and found out that unless I introduce myself as a physician to you, everybody in the hospital is a nurse. So I'll give you an example of that 4-wheeler accident. So we have a patient that's had a bad 4-wheeler accident. Let's say broke their leg. So they're coming in through ambulance. They come in through the ED. They see an ED physician, a triage nurse, the primary nurse in the ED. They may see a CNA in the ED. So now they identify, they do the x-rays. Now you've got imaging. You've got people doing lab work to make sure they're not bleeding internally. You got all sorts of people in that room. Well, now let's say they have to go to surgery. So now they're going to go to surgery directly from the ED up to surgery. Let's say it's after hours. So when I say it's after hours, usually after, what is it now, 6, 7 o'clock at night, they have to go to the recovery room to be recovered. But now think about surgery. You've got the main surgeon, the surgeon assist, you've got the circulating nurse, the first assist, you've got imaging people up there in surgery. Now they go to the ICU to be recovered. They do well enough, now they go to the floor. How many people do you think that patient has seen in that first 24 hours? Average of 47. Who's the nurse? When they answer these questions, who are they judging? Who do you think they're judging?
Judging everybody.
Right. But what was the answer you gave me when you fill out a survey? Who do you remember? The people that were explaining us. Right? Now, there are those, and this, always makes me feel good. There was, in my career now, it's been a while, that when I was doing bedside nursing and ICU nursing, I had 3 occasions where my patients actually became nurses because of the care they received. They were so inspired by what nurses did for them, they became nurses. But anyway, so now let's go back to this. So during your hospital stay, how did staff, because really, everybody's a nurse now, treat you with courtesy and respect? What's your definition of courtesy and respect? I can interview each one of you, and you give me a similar answer, but a lot of it's based on your past experience, right? Now, what is your definition? Does it mean that somebody sat down instead of standing over you? Instead of looking in the computer, typing in stuff, they actually did eye contact, took a minute, held your hand, did those things? It's all that connecting, being in that moment with the patient, making sure that they feel that they're the only one in your care right now. Because they want you 100%. They don't need 90% of you, they need 100%. Okay? So again, interestingly enough, when CMS decided there's 4 answers to this. Always, usually, sometimes, and never. So during this hospital stay, how often did staff treat you with courtesy and respect? Let's say you answered usually. What score would you think that would give you? 4 answers. That your A, B, C, and D scores in school. A would be your always, usually it's gonna be a B, sometimes a C, never a D or F, right? Well, according to CMS, unless you say always, you gave that hospital a 0. This is called top box. They expect you to perform at a level that that patient's always gonna feel and are treated with courtesy. Okay, so raises the bar, right? So now, how often did staff listen carefully to you? Did they not interrupt you? Did they take things down? Did they make sure you heard or were understood? You know, how do you judge that? Right? You judge it when you know you didn't get it. Right? And then during your hospital stay, how often did staff explain things in a way you could understand? I've been in healthcare so long, I forget the lingo I use sometimes. And I have to dial it back and make sure I'm communicating at a level. Interesting facts on Moscow, because the University of Idaho is here in Moscow, within the Moscow limits, city limits or close around, we have an average reading level of 8th grade. As soon as you leave that greater area, it drops to 6th grade. And sometimes we can take care of patients that are now usually in their 80s or 90s, that the only grade of school they completed might have been 4th or 5th. We have some farmers and loggers and people that, you know, that's how they made their living, and they were expected to go to work when they got to a certain age. And these patients could also be the same patients that don't have indoor plumbing, that heat their house with wood. And so now, after they've had that fractured leg, how are they going to go home? Is that a safe environment? So how do we make sure they go home in a safe environment? So those are all things that it takes a whole organization to do, just not one person. Okay. And then, again, the only answer to each of these is always. So when we talk about that always experience and being in that moment at 100%, because I can tell you back in the day, my twins were newborns. I had a 3-year-old at home, and there would be and I worked night shift. So I knew there were times that I may not have had a lot of sleep, and I work in ICU, and I have a patient on a ventilator, a breathing machine, I'm watching a patient. I mean, I would literally tell my backup nurse, because I may have been the only nurse in ICU, because we only had a 4-bed ICU when I was a nurse. I would call and have somebody come back and double check my meds. I would make sure I was getting safe care. Those are the things that you do to make sure that you're providing that care being in that moment. Okay. All right, interestingly enough, the same 3 questions are asked about doctors. Think about a time where you've interacted with a doctor, either as an inpatient, had surgery, had your visit with them. How much time did those doctors spend with you? I mean, not 5 minutes. Huh? Because bad on us as our healthcare system, physicians and providers are paid on volume, not quality. So the more patients you saw, the more income you have to pay your nurses, your front desk people, your billing people, your rent, your electricity. Doctors usually and providers, PAs and nurses and practitioners, they go into the job to run a business. They went into the job to help people. So that's why you see a lot of providers being employed or contracted employees of healthcare systems. It's because they don't have to worry about that stuff. We want them to take care of patients and do a good job. Okay, so how often did doctors treat you with courtesy and respect? Did that mean they didn't interrupt you as you were explaining why you were there, what you needed? Did they listen? And then did they explain things so they could understand? I went with my 80-year-old dad to all his appointments because he'd sit there and nod, and the doctor would spend an enormous amount of time explaining this to him. And as soon as he left the room, he'd go, "What is that?" Because he didn't understand all the jargon, right? So you gotta make sure you want them to say, "Now tell me what you heard me say," so that you make sure they understand, right? Close. Okay. During your hospital stay, how soon after you press the call button, did you get help? This is an interesting. What's your definition of soon? Yeah. Depends if you're in pain, you need to go to the bathroom really bad, or that, you need help to the chair, or you want a warm blanket, that's a different time. I mean, think about when you have the flu really bad at home, and you take cold medicine or whatever, you go to bed, and you wake up and you're like disoriented, and you're like, oh God, how long have I been asleep? 2 minutes, 20 minutes, 2 hours, 2 days, But think about having a season. That's disorienting. Think about now having just surgery, the trauma of surgery. That's going to disorient you. You almost lose a day in time and space, and it's hard to remember what's soon. You press all that, and it could have been instant. We've done studies on ours. Our call lines get answered within 5 seconds, 7 seconds. Now they get answered out at the nurse's station. Does that mean that they actually went to the room at that time? That's where you have this, like, you can't do that time. So maybe that's it. And then, of course, if you needed the bathroom. What's the only answer that counts? Oh. Okay, before giving any new medicine, how often did the hospital staff tell you what the medicine was for? Then did they explain the side effects? And then they did provide that in print. So we actually have a quadrant of a form that we will use to help orient people. Have you heard about in the boxes and nurses? Supplement search, they have whiteboards, and on their whiteboards there's an M, and it's in a box on their whiteboard. And it means, the M means there's a new medication the patient's on. And that M does not get erased until a patient can literally say back what the medicine is for and what the side effects are. And then that's erased so that we know the patient understands what that is. All right. Then during your hospital stay, did staff talk to you about how much pain you had and how to treat that pain? Now, there's been a big opioid crisis. These questions used to be different a few years ago. And this was sometimes blamed, these questions that CMS put out were sometimes blamed for the opioid crisis getting further down the road. Because if you're getting judged on your scores, what are you going to do? Give pain medicine. Yeah. Maybe not in an appropriate fashion, because that's what patients are. So again, now there's talking about how much pain. Did staff talk to you about it? Are they asking you for a pain scale? Are you treating their pain either by repositioning? It doesn't always have to be a medication. Okay. Then during your stay, did doctors, nurses, or others talk to you about whether you have the help you needed when you left the hospital? I gave you that example, and that's not uncommon. I have patients that have good heat, and we're going to send them after an orthopedic surgery thinking they're going to be able to heat their house. How do we set up neighbors, family, friends, churches, whatever we need to do to make sure that they have heat in their home? And then during your stay, did you get things in writing about what to look out for after you left? Because if you have a surgery and they're going, okay, make sure, you check your dressing, make sure there's no drainage on it, call if it gets hot and warm, if you have any issues with a fever, you want to make sure if there's something that's starting an infection that they're doing something. So we do what we call a follow-up phone call now. About 2 to 3 days after their discharge, a nurse calls the patient and asks them specific questions, and particularly if they've had surgery. Now, how's your wound look? How's your pain being controlled? When's your appointment? Did you pick up your medications? Because oddly enough, patients aren't going to tell you if they can't afford them. They'll just say, oh yeah, sure, I'll go pick those up, and they never do. So now you need to know. Interesting study, 28% of patients that were actually an inpatient, so I had to stay overnight, maybe 2 days, took prescribed medication correctly on leaving the hospital, 28%. What's the likelihood those patients are coming back? Not yet. So, interesting enough, CMS also watches your 30-day readmission and will penalize hospitals if they are too high. So, there's some now incentive of increasing your quality, right, for the admissions, is you want to make sure they're educated. Okay. During your hospital stay, staff took my preferences and family into deciding what my needs would be when they left. Because if you have somebody in that condition that has broken their leg, has outdoor plumbing, and with heat, that's not a safe place. So how can you work with them to find a place that is? Is it with family? Is it at a skilled nursing facility? And then when I left the hospital, I had good understanding of what I needed to do to manage them. We want to make sure we have almost like an action plan on what they need to do in their first 2 weeks when they left. And then I clearly understood the purpose of medication. And here this is strong. Because again, people aren't going to tell you if they don't understand when they have a lower than 6th grade reading level, because that's all our printed material is that 6th grade. They're not going to say, oh, I don't understand that. It's okay. We have a university, actually, the two, WSU and UNI. We have a number of foreign students. We need to provide them the education and what we're giving them in their writing of their choosing, so they can understand them, or provide interpreters. Okay. And then during your hospital stay, have the motion room bathroom kept clean. Seems pretty easy. Have you ever gone to a hotel where you have, well, I shouldn't stay here? Yeah, you walk in, it doesn't smell good. The furniture's worn out or whatever, and you're like, this might not be a good thing. Bed bugs, I don't know, yeah. And then during your hospital stay, was the area room kept quiet? This is our hardest one. Because obviously we have babies and admissions and everything for our stay. So this is the hardest one that is to work on. But again, always a simple answer. And then here's the 0 to 10. So 0 being the worst experience and 10 being the best, what number would you give yourself? Now, the example of always being the only answer, what numbers do you think only count for CMS? 9s and 10s. If you give a hospital an 8, you gave them a 0. So again, it's that high bar, right? And then, would you recommend it to your family and friends? I've got a lot of family and friends. They let me know if their care isn't so good. Now, obviously, I've been in the area for a long time. People have taken care of me for a long time, so they do provide me feedback. This was really great, but not so good. And so that's what we tried to look at. And we actually have a process, it's called Clarity, and you can hear about it later on, but we have a software system where anytime a patient enters a has a compliment, a complaint, an issue, whether it's billing, somebody was rude to me, we enter it into the system, track it, and investigate it, and respond back to the patient and to the person. So here with that. Okay, so let me show you some data. So I got to get back here so I can see. All right, so this is from December 2018 to November 2019. So right now, if you went to www.hospitalcare.gov, that is where CMS, Medicare, and Medicaid put all hospital reporting. So you could compare Brittman to Pullman, you could compare Brittman to Mayo Clinic, you could get Harborview over in Seattle. So you can compare hospitals on their care and how they rated on this survey. So here's that 0 to 10 with 0 being the worst and 10 being the best. Brittman, us as you, is in green. So you can see we're doing better than the database, which is all of Prescating hospitals, then which these two are the same. And then we have the American Hospital Association Region 8, which is the Northwest. And then the light blue is critical access hospitals, and I think Kara and Danny talked to you about that designation. So again, these are small hospitals, less than 25 inpatient beds. So you can see we're doing well above all the others for rating the hospital, recommending for family and friends. Here's where we're lower, communication with nurses. And you can see down in here where we have that issue. So right in here is where we need to work on listening and explaining. And then up here you can see responsive hospital staff, communication with doctors, again. And then hospital environment, communication about pain, medicine, discharge, and care. So just by looking at this graph, you know, the areas we need to work on is nurse communication with staff, and then communication with doctors. So again, you're just seeing that communication with doctors, and what do you think they need to work on? Explaining and what do you can understand. You know, make quietness. This is what I told you that week. But everything else, obviously, we're doing well on. Any questions on the survey? Anything? Told you the different standard. Okay, so now continuing readiness. So being the Joint Commission Coordinator at the facility, we are actually in our window for our surveyors to come unannounced. And there's usually 3 surveyors that show up. So one of them is the clinical or main surveyor that's responsible to survey the quality of care, the environment. Is usually another individual that looks at, do our fire alarms are not blocked? Is there exits not blocked? They're looking at the facility as a safe environment for patients and for workers. And then they added a disaster preparedness surveyor. So back in 9/11, Katrina, when they had all those disasters, they found hospitals were not prepared for the volume of patients that could be seen. So I'll give you an example for us. I think it was back in 2007, 2008. We had a University of Idaho student celebrating Cinco de Mayo a little too early in the day and borrowed a friend's car that later found out did not belong to the friend and hit the fire hydrant above our emergency department, which we later found was installed improperly. The fire hydrant actually sheared off and flooded our emergency department with 15 to 19 inches of water. The nice landscaping, you know, the bark that we put out there to make things look nice, it just plugged the drains. So the water just kept rising. So if you look at our ambulance bay, it actually is a decline into our ambulance area. So water would just come. So we moved 6 departments within 4 hours and did not close. We provided care continuously during that time. So obviously, when the water was coming in, which one of our doctors was like, what's this water on the floor? Went up to the ambulance bay, not thinking he was gonna trigger the automated doors. No. And we whoosh, out of pavement. So needless to say, we had to move the emergency department where wound care is now. We had to move wound care upstairs to another area so they could still provide services. And then it took phone, because think of all the phones that are specific to that department. We've got the computers, the charting systems. I mean, it was nuts. So we had to move all of that and get everybody repositioned and phones, jets changed and equipment. I mean, obviously gurneys and beds and anything, you know, think of where your outlets are. They're full of water, you don't want water and outlets, right? So this was all a good learning experience, but we literally, it was a big learning experience. We actually started the next day we started calling it the right hand, left hand meeting because we needed to know what the right hand was doing and so was the left hand. So we'd have these massive meetings every day at 10 a.m. to make sure we had everything covered. Because the other thing is we have our enunciator panel. So for those that are, if you're working in admissions, there's an enunciator panel that keeps track of where fires and freezer alarms are. And you have to man that 24-hour state. That's why it's in the video, because that's always got somebody there. Well, when it's flooded and out of commission, we literally had to have people sit there to watch that investigator. And then we had to do fire rounds. And so it took a lot of people. We had volunteer firefighters to ambulance people to our EMS system actually helped us out. It was great. Then about, well, it must have been either 7 or 10 days later. So if you took our emergency department, it's all now been torn apart. Drywall, because you can't have mold in a hospital, right? You know, spores and all that. So everything was cut at least 2 feet or more higher from the floor. So literally you could walk in to almost the meeting area, kind of just where the entrance is, and do this and see all the way into imaging, all the way into lab. I mean, it's crazy. So then we, all the partitions go up for safety and all those things. So we made sure EMS knew where our new ED was and how to come into the building to get to the new ED and all those things. So we made sure everybody was there. About 7 to 10 days later, we had our first mass shooting ever in the city. So we had an individual that had killed his wife at home, then went to a church and killed the caretaker of the church to get into the church, went up into the belfry of the church and fired 600 rounds at our police department, killing Officer Newbell in the line of duty. He was our first officer ever killed. And proceeded to, then I think there were 6 or 5 other victims from that shooting. I was the administrator on call, so each of us chiefs take our turn of call. We take 7 days at a time, 24 hours a day for 7 days. I got called about midnight saying we have a mass shooting. Now, we've never locked our doors. We never have locked our hospital doors prior to that, ever. And now I'm thinking, oh my gosh, so I'm throwing clothes on. I'm driving in here like a crazy woman, and I didn't ask her to shoot me. And then this stupid stuff goes through your brain, like, when you park, you run really fast straight, zigzag when you run in. I didn't even know where the shooter was. I was like, oh, great, that was fun. But again, we learned a lot of things from that. We learned how people bring in shooting victims. They don't come by ambulance. They threw them in cars and go through. Police, of course, having their first killed in the line of duty, they knew where the old emergency department was, not the new one. So they started tearing through all this plastic, trying to help. We made sure EMS knew it. So another lesson learned. So when we do these drills or have real life situations, we're meeting and trying to figure out how do we do it better next time. So that was 2 disasters within about 10 days. So, we finally get the hospital locked down. We're communicating with walkie-talkies. We had to go around to every first floor window to make sure it was closed. We had, having a modern facility that has how many wings and how many doors. And then our phone systems were flooded with calls. We had the Associated Press to the New York Times to everybody calling, trying to get information on our mass shooting. So we get through that. We continue to have our meetings of the right hand, left hand, and now we've added this mass shooting to it. 3 days later, we are calling what we call then a code pink. Now it's called a code amber. So you should have a little tag on here that gives you your codes. What's a code amber? So we had a family that had come to visit a patient, and their 2-year-old child was deaf. They had wandered away from the parents, and they couldn't find the child. So we initiated our code amber. So it's paged overhead. Departments in our hospital have specific places they can go. So like for mine is to go to the stairwell closest to my office and monitor the stairwell and actually check the stairwell for anybody trying to leave or abduct a child. Then we have other people people that actually leave the building and stand on the corner of each of our corners of our hospital to watch for anybody that they see with a bulky item that could be a child in a suitcase or whatever. So we were looking for those. So it just so happened, you know, some of our staff was like, you guys are kidding, you're doing this? And we're like, no, this is true. You're getting the identifying items of the 2-year-old, the brown hair, what the child was wearing, you know, anybody looking, you know, we need all hands on deck by this child. And it just so happened the person that was stationed at that corner saw the child start to cross Main Street between cars and actually got the child. And that saved the child. I mean, true. I mean, the child could have been hit, the child could have wandered even further away. So when we talk about our drills, or when we talk about our codes, there's a reason. And sadly to say, we had yet another shooting since this time, and that was 3 years ago, I think. We had an individual shoot and kill his stepmother and killed his landlord, and somebody that just happened to be visiting the landlord at the time got shot, injured, killed the manager of Arby's, and then we would get another. So when you don't think it can happen here, it can. And I would have never in a million years, you would have told me, and I was like, and as an FYI, it is guns can be carried on campus. We are in the state of Idaho, and that's been brewing. Oregon State, same thing. So when you think about the amount of guns that are in our area, you know, we're prepared to have it. Sadly to say, it's probably going to happen again. So how do you prepare? Because not only do we need you to protect yourself, because you're no good to anybody if you're injured. We need you to protect yourself so you can help others. And we have a lockdown system, and that's why your badges may not take you into certain areas because there's certain restricted areas. Family Birth Center is one of those. You have to get around and get into Family Birth Center. So child protection is reduced. You know, we have certain areas like pharmacy. Only pharmacists can go into pharmacy or allow somebody else to go in. Nobody else can go into a pharmacy because of obviously the drugs that they have up there. And the amount of sterility they have to have in it. Surgery as well. Those are just kind of some of the similar things. So when a surveyor comes, and it doesn't matter whether it's a surveyor or me or my group that comes around, if we're asking, you know, what do you do in your department? It sounds pretty silly, but it is just like, well, what is your job? When you think about it, what is your job? You know, we save lives. There's one department in this facility that can't say they don't save lives. And I can put cardiac rehab where they have saved lives. You know, these people have come after having their chest cracked open. They're high risk for all sorts of things, but yet they're learning to retain oxygen, be able to walk, be able to live a meal. You know, maybe simple as that, but they're saving lives. It's that connection. EBS saves lives. It's infection. If they didn't do their job, we would be rapid with infections. If admitting people didn't admit people correctly, with a photo ID, and being able to do true patient identifiers, we would have the wrong people billed, the wrong people receiving medication. So think about, there's not one department in here that doesn't say that. So that's the medication that we want you to walk away with. You make a difference every day you come here. I don't think you don't. If it was your parent or your child and you hear somebody say, oops, or you say, oh, that's not right. Is that what you do? Yeah. You want to be confident in the people that are providing you care. And it doesn't matter if you're moving them. It doesn't matter if you're helping them find their way from one end of this facility to another, because it's sometimes a maze. You know, our job here is to make people's life easier. So again, you know, what's my role? How am I trained to do my job? Safety concerns. Our number one priority is patient safety. That's what we're here for. to treat patients, to make them better. You know, it's a fun place to work. It is, I wouldn't be here if it wasn't, because I like to have fun. And then, what do I do in my department during the disasters that I can explain? Tell me more. We have times where the roads are closed because there's so much snow or there's ice, and they've closed the roads. How do we get supplies to maintain patient care? What happens if you guys can't come home at night? That's happened, where the roads are closed. We will find a place where you can sleep. We will make sure you have food, that you can take a shower in the morning, not them. So again, we want to make sure everyone is safe, not just patients, but each other. Okay, Sentinel alerts. So there are a number of occurrences that Joint Commission being an accredited agency. So there is the federal government that has rules for every hospital. For an example, if you have an emergency department, you have to have a defibrillator. It's like basic stuff like that. You have to have emergency medication, so on and so on. All right, but then you have state laws. In the state of Idaho, there's Idaho Code and IDAPA laws. So an example of that is informed consent, that we have to inform patients of the risks and benefits of the treatments that they're going to get. So then you have those laws. And then there's Joint Commission, DNV, HVAC, there's all sorts of vendors out there. But they do the same thing. They receive deemed status. So CMS taps them saying, yeah, you can survey on our behalf. And then they make sure we're following all the rules. So that's what the surveyors come in to do. Are you following all the rules and all the requirements to provide care and treatment? A sentinel event is one in which has caused a patient injury or death. And those are important. That's like the wrong surgery done. So an example is over in the Seattle area, there was a nurse that worked in a number of ORs, and in one of the operating rooms that she was working in, unbeknownst to her, and we don't know how this occurred, but she thought was saline in a basin of water. So saline is just something you drop in a syringe, inject it into the patient's intravenous line to make sure it was flushed and working and everything's right. Unbeknownst to that nurse, what she thought was saline was chlorhexidine. And chlorhexidine is the stuff that you clean the surface of the skin with. The patient died. So just in a blink of an eye, what you thought was a normal procedure, and she'd done it hundreds of times because she'd been an OR nurse for years, done the same way in every OR, one change that didn't get communicated. So from that injury, that death, Joint Commission put out a requirement that all basins, anything being transferred from its not original container that identified it, has to be labeled. So in surgery now, there's sterile pins and there's sterile labels that have to be put on every basin of what's in that basin. Every syringe. If you can't identify it, it gets thrown away. Expensive. We give chemo agents here that can cost up to $60,000. We don't want to pay them $60,000 on the patient. So again, we have processes. All right. So this is some more quality data. So we look at inpatients that pass away. Why? Were they on comfort care? Were they not? We look at all those things. We look at patients in labor, making sure their labors were appropriate. Unscheduled readmissions. So did they come back in that 30 days? Did they have to come back when they were just going to have an in and out procedure? Nausea, vomiting, pain, what happened? Some of our patients come in needing physical restraint. They're at risk of harming themselves or others, and we literally have to put them in a safe room. We have police that come in and monitor that as well. They may be under arrest and they have to stay that way. Bob talked a little bit about falls. We give patients medications. Anesthesia alone will cause you to be at a high risk of falling. And then unscheduled returns to the ED. You know, if you show up again in 72 hours, why? Did we not teach you something? Did you not get your medications? What happened? And then patients leaving before treatment's complete. Was it stay too long? And then inpatient measures, arrival to departure time we look at, decision to admit, elective deliveries, which really are not occurring very often anymore. Between 37 and 39 weeks, that puts the baby at a higher risk. C-section, breast milk feeding, which is the best, complications in term newborns, septic shock. And then more measures. We look at treating stroke patients, acute heart attack patients. We want to make sure we're following evidence-based medicine, and we do what the big hospitals do. Just because we're small doesn't mean we get excused. And then making sure we're identifying the patient correctly. That's our 2-patient identifier. We use SBAR, Situation Background Assessment and Request. That's a standard communication style that we use throughout the hospital. Our medication practices, we use barcode scanning, make sure our alarms are heard. We can make sure that if there's a heart alarm going off, an oxygen alarm, that everybody's aware. Preventing infection, you've heard talked a lot about that. And then preventing mistakes in surgery, we do a pre-checklist. And then these are our national patient safety goals, and you'll learn more about those in your departments if you adhere to them. Questions?
Sam says it's time to get started. No more loitering. All right. This is a really awesome group. Usually, sometimes we have a room that's filled, and it's nice to see that we are retaining some of our employees and not having, we want to keep that turnover down. We really appreciate you guys coming, and I'm sure you've gotten a really good snapshot this morning. You guys are joining a really amazing organization. How many of you guys have already worked in your areas? So almost everybody, okay. How many have worked there for a month or more? 3 weeks or more? 2 weeks? 1 week? Okay. And a couple days? Yeah, okay, all right. Well, welcome you guys. I'm gonna do this a little differently. So we're in transition, and you heard Kara talk about that this morning. My name is Scott Nelson. I'm the Chief Experience Officer. I believe, John, that's the second time I've said that. My background is in imaging. All my background is in radiology. So I've trained in X-ray, CT, and MRI. I got into leadership 10 years ago. Since I did most of my work here at Goodman Medical Center. And then about 6 years ago now, I had the opportunity to get into my first directorship. Actually, that was 10 years ago. And I had an opportunity to go over to Whitman Hospital in Colfax, Washington. You guys know where that is? It was a great opportunity, and it was super hard for me to leave here. In fact, Jeff Martin was the CEO at the time, and I wanted him to know that I wasn't leaving because I was disgruntled or I was unhappy with my job or anything like that. I just had this amazing opportunity to go over and be the director for their department. And Jeff was very gracious, which you'll find of all our administrators. We don't want to hold people back. We want you to advance in your careers. And so he gave me his blessing. He said, you can go on and do great things. And I left on my friend's here. I got a little Honda Civic and commuted back and forth because my wife and I at the time lived in Troy, which is 11 miles east of here. So I commuted about an hour a day in my Honda Civic. And this time of year was really challenging because the roads aren't so good between Pullman and Colfax. And I survived that. And the first year I spent thinking, what have I done? I have no idea how to be a leader. I have no idea what I'm doing here. And it was a lot of sleepless nights. And then our team, we started to collaborate together and we put things together. And after a year, I discovered that I really had a passion for leadership and working with others. And I think my greatest passion is helping others find your true potential and what you can do in your position. Every single position in our organization is so valuable. I have a couple stories I'd like to share with you. Some of them are atypical of how you as an individual can make a difference in someone's life. And it's being in that moment with that person is when those things happen to us. So I have a story, I also have a video I want to show you towards the end. That is one of my favorite videos because we have no idea how powerful sometimes our interactions and our words can be and how it affects somebody else. And a lot of times we don't hear the rest of the story, but in this case we do get to hear the rest of the story. So it's really cool. Passing out, maybe more. Okay, super. You guys gotta keep track of this. So just a little bit about me. I have been married now to Lisa Marie for 22 or 30 years, sometimes. We actually just had our anniversary December 21st. We have 3 kids. Our son Joshua is 22 years old, works for Northwest River Supply. This is do you guys know Northwest River Supply?
They just built that.
They did, the big complex,
right
in East Town, yeah. Yeah, you didn't know that was going on before you moved in, like, no, It's a rafting company that makes rafts all over the world. In fact, we took a group of high school kids, my wife teaches English art in Detroit, and we took a group of high school kids to Costa Rica, and we went on a rafting trip there, and we were sitting on Northwest River Supply rafts. It was really cool. We're like, this is our home, this is Mount Fido. So it's a great culture here, a great community. Our daughter Olivia is 19. She's up at the university. Somehow she's a junior already. You know, they let them take these classes ahead of time and earn credit for college. And so she's a junior. And then our daughter Rosalind is a senior in high school. So it's been an amazing adventure and experience. And how many of you guys have kids? Okay, good majority of us. I always feel like with kids that I have their, whatever state they're in figured out, and then they're moving on to the next state. So I'm always a step behind, and I think I've come to terms with that. You've got twins, so you're in double trouble. All right, so I want to talk to you guys about experience, excellence, and before I do that, the piece of paper that I handed out to you, I'd like you to just write down a couple of things. One, what do you want to bring to the organization? You guys are all coming with amazing experiences, professional, personal, very rich in your lives. So in your new position, what do you want to bring to that experience? And you heard Kara Best talk about our 3 customers. Can we name them as a group? Our 3 customers: patients, providers, physicians, and co-workers, each other. Yeah, and you'll hear that a lot. It's been new focus and new initiatives of really seeing perspectives from all 3 of those perspectives. So in your new role, what you're bringing, all your talents and skills, what do you want to do in your position to inspire, to create a great experience for those 3 customers? So that's the first question. And then the second question is, what are you hoping to get from the organization? Because this is a symbiotic relationship, 2-way street. What do you want from the organization?
Yeah.
All right, it looks like teams are kind of finishing up here. So anybody want to share what they wanted to bring to the organization? I know that's a scary one. Just jump right off and now you're more today.
Sure, I'll say it. I wrote down that I want to bring consistent, high-quality food to everyone that eats it, and I hope to engage and inspire people in my department to elevate the food.
Nice. I love that. That's a mission statement. You know, one thing that you said in your first sentence, consistency. You guys heard Kara say that this morning, and you're going to hear that a lot. That's what I've been working with my teams about. There's a book we're going to talk about, Good to Great. You don't have to read it unless you want to read it. But it's all about consistency. And that is the difference between good work and great work. Being consistent. We all want that.
In the food world, that's the difference between a nice restaurant and a Michelin star restaurant.
Right, yeah. 2 stars, 5 star, right?
Well, I think the difference between 2-star and a 5-star is who's reviewing it.
Okay.
I rate all mine 5 stars. So, I'm 5 stars.
Yes. It's
Yeah.
called managing up, and it's also important to have a very good culture. You need to manage others. Anybody else want to share what they want to bring to the organization? You know why I think this one is hard? We, healthcare workers, we have a hard time managing ourselves up a little bit, right? And we're allowed to. It's okay to celebrate the skills and the talents of everybody. So yeah.
I was just saying, I want to bring joy.
Yeah. Sweet.
I want to be a healthy person.
Yeah.
Whoever needs my help.
Awesome. Your aura says all that about you, right? Especially, and I gotta admit, I don't know who else is, but I'm jealous of your hair. I used to have long hair. Okay, anybody else want to share? How about what do you want to get from an organization?
Want to build.
Paycheck, right?
I want experience. I also want to be a PT.
Yes.
That's what I want to do. And so I want experience in the potential field I'm going into. I also want to build connections.
Yeah.
So I can't expect you to do everything, on my
Yeah.
own. I need help from other people. So.
Yeah, and you haven't been over there very much, right?
I've been there, I actually had PT done there myself.
Okay, yeah. Who was your therapist?
Dr. Barbudo.
Okay.
Yeah.
Very nice. Yeah. I spent some time over there with my son just so last September. Last year, Cliff was my therapist. Amazing. Justin's got a great team over there. So, anybody else want to share what you want to receive from the organization? Okay, that's okay. All right, so we're going to go through some slides. Some of the slides I'm going to skip because you've seen some of these. So experience excellence. And I think just in hearing the conversations around the table, serving others, that's why you guys are here in healthcare. I mean, you have the choice to go work for lots of different restaurants, and you brought a different perspective to it. So serving others, and I feel like this is a gift. And the reason I feel like this is a gift, we all have different political views, right? If we did a survey, which we're not going to do, we all probably have different spiritual beliefs. We all have different walks of life that we come from, all those things. And the cool thing about it, when we're serving others, it doesn't matter, does it? It helps us get out of ourselves and be servants to other people, and it's an amazing experience. It's an amazing, meaningful work that we do every day. So that, to me, has been a gift for me. I don't have to worry about, what's this patient's political view? What's their religious? It doesn't matter to me. This is taking care of that patient. Being in that moment is an amazing experience. Sometimes I think it gives more to us than maybe we do to them sometimes, even though we're trying to go above and beyond. Got too quick with the clicker. So you guys were introduced, I think, this morning a little bit to the values. And the one question about values is, you see them posted on our walls, which you will. And then this is the true test, especially being newest to the organization. Are people really living the values? Are they committed to the values? You're going to find your leader totally committed to the values. And he's very familiar with Prince Suter. We have rearranged this, and Connie, that was just in here working with you guys, she came up with this really cool thing. And I'm going to rearrange this on the next slide for next year. But this is, Connie came up with CI Care. So we are rearranging so that it was compassion, integrity, collaboration, acceptance, respect, and excellence. It was a really easy way to remember them. And the one thing is, hopefully when you signed on with our organization, all those values lined up with your values and what you want to bring to your position, what you want to bring to your coworkers, your physicians, and to the patients. So I ask my employees, because we are human, right? Last time we checked, and we're going to make mistakes. And there are times when stress or a situation is going to come up we weren't expecting, and we're going to probably violate one of these values. And the important thing is recognizing that, making amends as quickly as you can, and getting back on track. These help us stay on track. So I ask my employees, and I talk about this in redundancy, so they're probably totally sick of it. But I say every day is a new day. No matter what happened yesterday, today is a new day, and we clock in. You'll see if you do it on the time clock, you'll see above there a plaque that Justin helped make with the engagement team, and it has our values on there. And instead of just blowing by those, be in the moment and recommit to the values every day. You have an opportunity to recommit to those. And if you do that, these amazing experiences, amazing collaboration can come about. Part of it is, has anybody heard assuming positive intent? So this was another gift to me, and I want to give it to you. Because for much of my life, and now I do teach a class called Crucial Conversations, much of my life I would spend knowing that why another person did something. Like I could guess their motives, I know exactly why they did that, right? We do this as human beings. We make up stories in our head to try and figure out why somebody did a certain action. And it took me almost half a century, I'm embarrassed to say, that when I guess other people's motives, I'm pretty much 99.9% of the time wrong. And so assuming a positive intent goes like this. I see something that's like, gosh, that didn't feel right, or I don't understand why this coworker did that. And instead of going up to Sam and saying, can you believe Skylar did that? I can't believe that guy did that. I actually go up to Skylar thinking, you know, I bet he didn't show up today to do a bad job or to insult me or any of that. So maybe I'm wrong about what I think I saw or I think I heard. So I go up to Skylar and say, man, when this happened, I don't know what was going on, but it didn't seem right. Can you help me understand what was going on? We teach classes like that for conflict resolution that you guys will all be eligible for. And it's amazing because in interviews, how many of you got the question of how do you handle conflict? It's a very common question in interviews. And when I sit in on interview committees, what do you think the answer is I most look at? I don't like conflict, right? I like to avoid conflict at all costs. I walk the other way when I see that person, don't want to talk to them. I'm like, oh my gosh, they're on my shift again. Oh. And it teaches you actually to have those conversations and get really positive results. We as an organization, I can expect my staff to be best friends or like each other. I hope that they do. I hope this is what they do. But I can't expect that we agree to live by these. So even if we have a little bit of personality differences, we can come together for a greater purpose, which is patients. So that keeps our common goal. All right, enough of that. So here is a little bit of every organization goes through a journey, and the organizations you guys are coming from have gone through journeys. And I want to share just a little bit of the past history of this organization, the journey they've gone on. So there was a time when this organization, Fred Lee, wrote a book, If Disney Ran Your Hospital, 9.5 things you do differently. I actually wasn't here with the organization during this time, so I can't give you a lot of information on that. The one takeaway I can give you is, as healthcare providers, you are always on, Disney said it differently, I'm sure, but you're always on set. What does that mean to you guys?
Doing your role that you're in, so not PTA donor, not that whole donor.
Yeah. So when you're in your PT role, who's watching?
Everybody.
Everybody, right? So are patients watching when, if I work over there in PT with you, you and I are having a conversation, they watching that?
Yeah.
They listening to what we're saying? Listening to how we're saying it to each other? And how much of that contributes to the culture and the feeling you have as a patient? You guys have all been there, right? In situations where you've been either in a doctor's office or a hospital or a dentist's office, and somebody was upset with another worker, and then how do you feel as a patient in that situation? You feel like you're going to get great care, or these guys are collaborating in a process. It's a really uncomfortable feeling. So being aware, and I think that's the one thing I take away from that is, and don't get me wrong, none of us are active, and none of us should not be being true to ourselves and genuine to who we are. And we should be very aware if we're having any kind of negative feelings, or we have, I gotta go talk to Skylar because he knows that we did this thing again. I need to be very careful who's listening, who's watching. Over in radiology, there's a hallway, there's the waiting area, and then there's a hallway. And in between that, there is the technologist area on this side and that ancillary on this side. Sometimes they'll meet in the middle of the hallway. And hallway conversations are great for getting a lot of things done. However, if we have that conversation there, guess who can hear? Everybody in the waiting room. So we have learned, oh my gosh, we need to, and it's easy to get caught up in that. We need to take that into a private room and have that conversation so people aren't overhearing that. Jim Collins, this is the book I was talking about. You mentioned it, Consistency. This is a book, Good to Great. I think it pertains to any area, any industry. I was really for healthcare. These are steps of how do we get more consistent? How do we get to that higher level of organization so that we are a high reliable organization? And it goes back to consistency. Quint Studer. Quint Studer was a CEO. He is now retired. He wrote this book, Hardwiring to Excellence. You'll see a lot of our pillars that Kara showed you. The slide I'm going to skip in this one. This is really purpose, meaning, worthwhile work, what we do. This book pertains to, I have a friend who's a farmer, and he manages about 6 people. And he said, man, I'm really struggling with how to manage these guys. I said, you need to read this book. So it's a really quick read. It is amazing. Really get into purpose and meaning, worthwhile work. We, as an organization, really value servant leadership, serving others. And as Karen mentioned this morning, that's our 3 customers. So serving all 3 of those customers. How can I make the person who's in front of me today have a better day? How can I make it easier for them? Those are the questions. And you're going to get a lot of those in your position. You are the hub of everything going wrong in the building aspect, right? Shared governance. You probably have already heard this today. If not, I'm going to repeat it, and then you'll work with Brandy later today in the lean processes. Best ideas come from frontline staff, and best ideas come from your employees. So your 30-day review and 90-day review, one of the questions is going to be, do you guys see any processes that you believe could be improved? And oftentimes you hesitate because it's like, oh my gosh, I'm the new person on the block. I don't know if I should be speaking up yet. And we actually encourage it because you have the precious eyes. You guys are going to see what we call processes, and you're going to go, why did they do it like that? That's like a total workaround. And we've been doing it for so long that some of our workarounds now look like processes to us. So the continuous process improvement, continually asking, why? Why do we do this? Well, because that's how we've always done it, right? That no longer applies. So you guys are bringing a lot of value with your fresh eyes. All right, this is the one I'm going to skip. You guys okay with me skipping this one? Okay. Not that it's not valuable. That is the pillars of our hospital. I know Kara reviewed that with you guys this morning. You will see it on your computers. You'll see it a lot throughout the organization. This slide I love. So we have our culture, and some of you guys have worked in your position more than a couple weeks. Even some of you that are just a couple days, you're picking up on people know each other by names here. They address each other. It's a very friendly organization. And we also have strategy. Kara talked about the strategic planning that we're doing, initiatives. If you have culture, culture beats Trump's strategy every time. So that's the starting point. And if you have culture plus strategy, we are as an organization unbeatable. There's nothing that we can't do if we have those 2 things. That's what we've been purposely striving for as an organization, to put those 2 together. 3 customers, right? Defining the patient experience. This is all the interactions shaped by our organization's cultures that influence patient perception across the continuum. Question for you guys. Is perception reality? Somebody's reality, right?
Yeah.
I know I see shaking heads now. Somebody's reality, but it might not be our reality. If you have a patient who has a bad experience, their perception of it, that may not be our reality, but we have to address it as if it is, right? So we have to bring those 2 discrepancies together and really address what does the patient need to listen, to offer that apology. And an apology often goes, we're sorry that our care for you didn't live up to your expectations. Because we may have done everything that we could have done in that situation, and sometimes things just don't go right. So Those are things that we have to consider. All right, so that's a big, really busy slide. Always patient experience. It kind of lists everyone. I think the main takeaway of this slide is every single position in the hospital is very valuable. And every single one of us, no matter what your position, we are caregivers. Patients see us as caregivers, so if you're going in and out of rooms, they're engaging with them. We are all taking care of others. And I heard a CEO speak recently, and he said that we do two things every day for our patients, for our physicians, for each other. And then it made me think this is what we do for our families too. We take care of physical needs. Like people have some kind of ailment, you had to go to PT, I had to go to PT, and we take care of their emotional needs. People sometimes are have high anxiety about coming to the hospital, they don't want to be here, and so we're taking care of two of those things, and that's what we do. And when I think about it, there's not much else. Physical needs, emotional needs. Here are the top 10 reasons why patients recommend a hospital. Hospitals' overall cheerfulness, how people interact with each other, staff sensitivity to inconvenience of hospitalization, recognizing that nobody wants to be here, it's uncomfortable, and to tell you the truth, I'm scared of what you might find out. In radiology, sometimes in MRI we can do this, we can't do an X-ray, but we can do experimental exams. You know, we have new technologists in these who know how to do a lumbar spine, or an ultrasound sonographer who needs to do an abdomen or something. And I have been a guinea pig in the past, but you know what I tell them? You can practice on me, don't find anything wrong. Right? It's scary when you get imaged. Like they might find something that's wrong. So staff are informed about the medical tests, or your area, or the food service, or the engineering, the building, whatever area you work in, inform yourself so that you can answer those questions. Adequate information is also given to the family and addressed to them, and staff are attentive to special needs. Staff take problems seriously and listen. Again, friendliness of staff. Staff concerned about patient privacy, and has Kane talked to you guys yet today? He'll talk to you about HIPAA, the laws of HIPAA rules. It's very, very sensitive and important to people. Courtesy, information, admissions, personnel, and then number 10 is technical skills. There was a whole lot before we even got to technical skills of what is important. I want to show you these three, and I'm going to go through this fairly quickly. The job engagement, organizational engagement, and overall satisfaction. This was taken, I believe, from 2018. This was with Health Streams. We're now with Press Ganey, so next year, this spring will look a little bit differently. But the important thing, here's the national norms, and here's our norms. So when we look at job engagement, 60% are strongly in agreement of that. We only had dissatisfied, we had 5%, which is national norm, but agree and strongly agree compared to the national norm here. For the organizational engagement, 55% strongly agree, 38% is the minimum, or the middle of the road. 40% agree, 50%. So we had more go up to the strongly agree in the organizational engagement. And then the last one, overall satisfaction, very satisfied, 49th percentile, as opposed to the norm, which is 33 and 46. So we have almost everybody up in very satisfied or satisfied. So again, I tell you, you're joining a really great organization. These are some of the scores that come off of that. And what I'm going to point out as far as administrative trust, keeping staff, your job opportunities, and those for you, understanding needs, employee recognition, learning opportunities, fairness of promotion, managing the facility communication, and constructive feedback. When you look at this column, now these are percentiles. So 50th percentile is where half of the organizations are, and we are at anywhere from the 77th percentile all the way up to the 86th percentile. So really, really high, and we continue to see those high scores. So I'm not gonna have you write this down because we already did a writing activity. What does feeling valued look like to you? I just want you to think about that. This gets into our purpose, our worthwhile work, how you make a difference. And I want to share this quick story with you, and then I'm going to show you a video. And then I think we're going to break this section. So when I was the director of Whitman Hospital, I lived in Troy. So I always stopped at the McDonald's and home on the way back. And I would get a coffee because I'm a coffee addict. The coffee's there, I think, with them. Maybe during this session. And when I would go there, there was a guy who worked there named John. He was from the South. He was a big guy. I called him Big John. My kids are like, is his name Big John? I'm like, I don't know. That's what I call him. He's a big, strong guy. And he was so customer friendly, would engage in conversations that I found myself starting to really look forward to get my cup of coffee and talking to Big John. And one day, and you know, I couldn't make it between pullbacks and Troy without having coffee. One day I showed up, and Big John was not at the first window, he was at the second window, and I ordered my cup of coffee, and then I pulled up to pay, and then I saw the next window, he leaned out, and he's like, gave one, and then he disappeared, and I'm like, I don't know what he's talking about. And as I pulled up, he said, and he always called me boss, I'm sure he called everybody boss, but for some reason when people call you, that's like feels good, right? Hey boss, how you doing? He said, hey boss, how you doing? I just want you to know there was only this much coffee left in the pot, and so I'm making you a fresh pot of coffee. Now, intellectually, I knew that fresh pot of coffee was for me and everybody behind it that wanted coffee, right? But in that moment, it really felt, man, what a guy, he's making a whole, so if you could just please pull forward, I'll get you a cup of coffee. Now, everywhere I go, I compare my service to, do they live up to Big John? And I bet you if I asked you, if we had time and went around, like, who is that person in your life? And I have nurses, I have nursing stories I can tell you, we don't have enough time. But who is that person in your life? That you, I don't even know, I barely know this guy. And 6 years later, I'm still telling the same story because that's the difference in somebody, like my day, no matter what happened in the day, life was good. Big John gave me a cup of coffee, we could have a friendly conversation. So it's really amazing. In your roles, you're going to have the opportunity to know what people may be talking about you. I don't know where Big John lives. He's not over there anymore. He has no idea, but really powerful inspiration. So I'm going to show you guys a quick video. Do you guys have any questions for me? Okay, I want to welcome you. I'm glad you're joining our organization. My office is over by the ER Physicians parking lot, which is just around the corner. It's by the cafe. I'm very thankful and blessed to be for you. My door is always open. If you guys need anything, don't hesitate to stop in by. Let me know how the job is going. I'd love to hear about it. If you need any help with that, I'd love to help with that as well. So I'm going to show you a video now. I thought we'd have time for 2 videos, but I talked too long. Sorry. But this video is so powerful because this is one of those Big John stories where the Big John character gets to hear the rest of the story. And every time I see it, it gives me a chill. So I'm going to bring that up for you. We're skipping a whole lot of slides, John. Yeah.
Google Glass. A phone plan by Google. If a bunch of babies need a phone plan.
You guys want to watch the ads or you want me to skip it? Okay, just check it.
I want to start by asking everyone in the audience here a question. How many of you are completely comfortable with calling yourselves a leader? See, I've asked that question all the way across the country, and everywhere I ask it, no matter where, there's always a huge portion of the audience that won't put up their hand. And I've come to realize that we have made leadership into something bigger than us. We made it into something beyond us. We made it about changing the world. And we've taken this title of leader and we treat it as if it's something that one day we're going to deserve. But to give it to ourselves right now means a level of arrogance or cockiness that we're not comfortable with. And I worry sometimes that we spend so much time celebrating amazing things that hardly anybody can do, that we convince ourselves that those are the only things we're celebrating. And we start to devalue the things that we can do every day. We start to take moments where we truly are a leader, and we don't let ourselves take credit for it, and we don't let ourselves feel good about it. And I've been lucky enough over the last 10 years to work with some amazing people who have helped me redefine leadership in a way that I think has made me happy. With my short time today, I just want to share with you the one story that is probably most responsible for that redefinition. I went to a school on a little school called Mount Allison University in Saskatchewan, New Brunswick. And on my last day there, a girl came up to me and she said, I remember the first time that I met you. And then she told me a story that happened 4 years earlier. She said, on the day before I started university, I was in a hotel room with my mom and my dad. And I was so scared and so convinced that I couldn't do this, that I wasn't ready for university, that I just burst into tears. And my mom and my dad were amazing. They were like, look, we know you're scared, but let's just go tomorrow. Let's go to the first day. And if at any point you feel as if you can't do this, that's fine. Just tell us and we'll take you home. We love you no matter what. And she said, so I went the next day and I was standing in line getting ready for registration. And I looked around and I just knew I couldn't do it. I knew I wasn't ready. I knew I had to quit. And she said, I made that decision. And as soon as I made it, there was an incredible feeling of peace that came over me. And I turned to my mom and my dad to tell them that we needed to go home. And just at that moment, you came out of the student union building wearing the stupidest hat I have ever seen in my life. It was awesome. And you had a big sign, promoting Shine Around, which is Students Fighting Cystic Fibrosis, a charity I've worked with for years. And you had a bucket full of lollipops. And you were walking along, you were handing the lollipops out to people in line and talking about Shine Around. And all of a sudden, you got to me, and you just stopped, and you stared. It's creepy. This girl right here knows exactly what I'm talking about. And then you looked at the guy next to me, and you smiled, and you reached in your bucket, you pulled out a lollipop, and you held it out to him. And you said, you need to give a lollipop to the beautiful woman standing next to you. And she said, I have never seen anyone get more embarrassed faster in my life. He turned beet red. He wouldn't even look at me. He just kind of held the lollipop out like this. And I felt so bad for this dude that I took the lollipop. And as soon as I did, you got this incredibly severe look on your face, and you looked at my mom and my dad, and you said, look at that. Look at that. First day away from home, and already she's taking candy from a stranger. And she said everybody lost it. 20 feet in every direction, everyone started to howl. And I know this is cheesy, and I don't know why I'm telling you this. But in that moment when everyone was laughing, I knew that I shouldn't quit. I knew that I was where I was supposed to be, and I knew that I was home. And I haven't spoken to you once in the 4 years since that day, but I heard that you were leaving. And I had to come up and tell you that you've been an incredibly important person in my life, and I'm going to miss you. Good luck. And she walks away, kind of flat. And she gets about 6 feet away, she turns around and smiles and goes, you should probably know this too. I'm still dating that guy 4 years later. A year and a half after I moved to Toronto, I got an invitation to their wedding. Here's the kicker, I don't remember that. I have no recollection of that moment, and I've searched my memory bank because that is funny, and I should remember doing it, and I don't remember it. And that was such an eye-opening, transformative moment for me to think that maybe the biggest impact I've ever had on anyone's life, a moment that had a woman walk up to a stranger 4 years later and say, you've been an incredibly important person in my life, was a moment that I didn't even remember. How many of you guys have a lollipop moment, a moment where someone said something or did something that you feel fundamentally made your life better? All right. How many of you told that person they did? Why not? We celebrate birthdays where all you have to do is not die for 365 days. And yet we let people who have made our lives better walk around without knowing it. And every single one of you has been a catalyst for a lollipop. You have made someone's life better by something that you said or that you did. And if you think you haven't, think about all the hands that didn't go back up when I asked that question. You're just one of the people who hasn't been told. But it is so scary to think of ourselves as that powerful. It can be frightening to think that we can matter that much to other people. Because as long as we make leadership something bigger than us, as long as we keep leadership something beyond us, as long as we make it about changing the world, we give ourselves an excuse not to expect it every day from ourselves and from each other. Marianne Williams has said, our greatest fear is not that we are inadequate. Our greatest fear is that we are powerful beyond measure. It is our light and not our darkness that frightens us. And my call to action today is that we need to get over that. We need to get over our fear of how extraordinarily powerful we can be in each other's lives. We need to get over it so we can move beyond it. And our little brothers and our little sisters, and one day our kids, or our kids right now, can watch us start to value the impact we can have on each other's lives more than money and power and titles and influence. We need to redefine leadership as being about lollipop moments. How many of them we create, how many of them we acknowledge, how many of them we pay forward, and how many of them we say thank you for. Because we've made leadership about changing the world, and there is no world. There's only 6 billion understandings of it. And if you change one person's understanding of it, one person's understanding of what they're capable of, one person's understanding of how much people care about them, one person's understanding of how powerful and agents of change they can be in this world, you change the whole thing. And if we can understand leadership like that, I think we can redefine leadership like that, I think we can change everything. And it's a simple idea, but I don't think it's a small one. And I want to thank you all so much for letting me share it with you today. Have a great day at TED. I'll see you later.
Keep the formula. Well, the real formula. But the old option.
You guys like that story? It's one of my favorites. So I am done. I want to thank you guys for your attention and your time. I know it's hard right before lunch. Derek Steyer, our safety officer, is going to talk to you guys next, and then we'll do lunch. Sound good? Okay.
So Scott would make me go between that great video and lunch, but bear with me. So my name is Derek Steyer. I'm the Director of Safety and Security. I'm just going to go over a brief safety presentation for you guys, kind of cover what our environment of care team does, kind of what it consists of, and then kind of some security aspects and some code response. So we have a variety of codes, and we'll kind of touch on what responses for staff for those things. So just jumping right into it, our environment of care is comprised of these component parts: safety, security, fire safety, hazmat, hazardous materials, and emergency preparedness. So we have plans for each of these points of emphasis that we look at as part of our environment of care committee. So we have 6 meetings a year. Every other month, our environment of care team gets together and we create plans for these. We look at policies, we evaluate security incidents, safety incidents, things like that will be brought up in that environment of care team. That team also does, members of that committee also do environment care rounding. So in whatever department you guys are in, you'll see a group of 5 or 6 of us, I think it is now, either once or twice a year, depending on if you're clinical or non-clinical, coming through and just kind of doing a joint commission preparedness kind of check, making sure that everything is on the up and up as far as with the joint commission requirements. So breaking these out, safety, that kind of encompasses, our slips, trips, falls. That's for patients and staff and visitors, everyone on our facility. Sharps, needle sticks, anytime we have any pokes or post exposures, those things are listed under our safety category and they're reviewed through our environment of care. And then the environmental tours, as I mentioned earlier, that's that group of people going around and making sure that we're ready for a joint commission survey. The different reports and documentation come from that, work comp reports, so on. Policies are derived from safety incidences. So if there's something that we've noticed with like patient handling, that used to be something that created some issues as far as like work comp claims. So policies were created to try to remediate that. And then again, speaking with the safety aspect of it, that really goes for everybody that's here. So not just staff, not just visitors, but everyone. Our 3 customers, if you guys have heard that term yet, ever heard that a couple times in orientation? Yeah, okay. So security, that's really important that everyone kind of has a situational awareness. So when you're in your areas, when you're fulfilling whatever function it is that you're here to fulfill, you have a situational awareness of if there's somebody in your area that maybe is acting inappropriately or maybe they don't belong in that particular area, you're always free to ask them if they've been helped, if there's anything you can help them with. If they're acting inappropriately, aggressively, something like that, you can absolutely call myself or the house supervisor. You can also call the police. I mean, if there's an instance where you feel that you're threatened, you don't have to be afraid to call the police. We're really trying to eradicate that thought process that somehow you'll be punished if you call the police because you thought that there was an incident that required their presence. So don't ever think that you can't do that. Because again, I'm not always going to be here. I'm not here 24/7. House supervisor is, but sometimes they're going to be busy. And does everyone know the house supervisor's role? So they're a nurse administrator, and basically they're running the house all the time. So they control patient flows. The helicopters are the ones that are going to call them, send patients hither and yon through that process. But they're also a great resource if you have questions about. I see Sam, you're in EVS, so when you're in the world of cleaning rooms and there's 10 things that need to go on, you can call the house supervisor and they can provide guidance. So they know kind of the pulse of the whole organization. So they're a great resource in many, many ways. We have processes in place for if we identify someone that really shouldn't be on our campus, we can issue them what's called a notice of trespass order. So that essentially is just a document that says, hey, you can't come onto our property unless you're here to receive emergency care. So we don't just hand those out. That's something that if there is a security incident that comes up, if staff are feeling threatened by a person or if it's disruptive to patient care in any way, we can issue those. And we send out a list of those to department directors and they'll share with staff, admitting staff. It's important that they see those, EVS staff as well, because they're kind of eyes on entrances, to make sure that in our waiting areas, people are, safe and secure, not being harassed, and anything like that. We have different security equipment, badge access doors, security controlled areas. That's why you have these handy dandy little ID card badges that you can swipe on the doors and they get you access into the building. Those are some of the security equipment measures that we have in place. Security cameras as well. We have those throughout the facility that we use to track if there's any sort of security incident. We need to look back on footage of that. We have that available as well. And security policies and procedures, again, we have a pretty expansive security plan that, again, our EOC regulates annually and evaluates its effectiveness to make sure that, we're providing a secure environment for everyone that comes here and looking at ways that we can improve that, such as like offering MOAB classes to staff who've done that in the past. It's management of aggressive behaviors. Anybody taken that class before? So we did that a couple years ago and it might come up again. So that's just a way to kind of prepare folks to be able to deal with aggressive behavior if there's somebody that's acting inappropriately to staff. Fire safety. This is really important for everybody to know. Everybody familiar with RACE? That's really important for everyone to know. It's also on your badge. You guys all have shining badges, I'm guessing. So you have this card here in between them, and it has RACE and PASS on it. And so RACE, essentially, if there's a fire in your area, you want to rescue people away from the immediate fire danger, activate a pull station if it's nearby. So that will send off our strobes and alarms. There's a pull station over there on the wall, the little firebox. Contain, that would be to close all the doors and everything and make sure that area was, the hallways are clear of anything in the way that will inhibit egress through that area. And then if it's safe to do so, try to extinguish the fire. So if it's a little fire, the size of like a wastebasket or something in that neighborhood, that's safe to attempt to extinguish that. If you open a door and there's a blaze, the whole room is full of fire, you're not going to deal with that with a fire extinguisher, right? So that's not safe, so you'd want to evacuate that area into a different smoke compartment. I forget that we had slides on that. So that's our red box activation. And then these doors are smoke doors. So when they close, they will close when that pull station is pulled. And that's to create smoke compartments so as to keep smoke from just traveling throughout the facility. Because the real danger with a fire in a building is the smoke, right? The smoke inhalation is what's going to cause the real damage to people within the building. Then our other little cheat code here on our badge is PASS. So that again is pull the pin from the extinguisher, aim it at the base of the fire, squeeze it to discharge it, sweep across the base of the fire. Again, base of the fire, base of the fire, base of the fire. That's really important to remember because that's where the flame is, right? The smoke's up here, the flame's down at the bottom. So that's the most effective way to extinguish that fire. And again, if the fire cannot be extinguished in your smoke compartment, you need to get out of that area. They show this picture, that's into our ED area. That's, again, one of those doors that's going to close when that pull station is activated. And those doors are actually just on the other side of the hallway from that. So those are your fire protection features. You've all seen sprinklers before. These guys are just like smoke detectors that you have in your house. They fulfill the same function. Any questions on fire safety before I get out of that? Okay, awesome. So then hazmat is another aspect of our EOC, and the really important piece to this is the safety data sheets. I know here it even says material safety data sheets. It used to be called safety data sheets, and then they switched to MSDS, material safety data sheets. Now they're back to just safety data sheets. It's not really that important of a difference, but it's important to know what they are, and I'll kind of go through that. Just kind of broad strokes. It just kind of tells you what to do if there's an exposure to them and kind of what PPE you need and how to store them. But this is what the information that you'll find on a safety data sheet will comprise, and it's broken out into this standard form that each is going to have these sections that tell you these more specific details of each chemical. And so we as an employer have to make sure that you have readily available access to this, our database of SDS. So anytime we have any sort of new chemical or a hazardous drug or something come into the facility, we are then responsible to make sure that we have that safety data sheet so that all staff can look at that if and when they need to. So it's ideal that folks would see these safety data sheets before they used whatever the chemical was. That doesn't always happen, but it's important that these are available to you guys. And if I have a couple seconds at the end, I'll show you guys how to get to them in our system. Emergency preparedness. Our emergency preparedness plan is based off of what's called an HVA, or a hazard vulnerability analysis. And that's essentially looking at the organization as a whole and what our kind of big concerns are as far as what's going to cause an emergency situation for our facility. So here in this community, something that would cause kind of our higher risk is severe weather. So that's something that could shut down roadways, and supplies coming in would maybe not be available to us. Our linens, and those are brought in from an outside source, so maybe like our supply lines would be cut. So how do we deal with that? So then our emergency preparedness team we'll look at that HVA and see those top items, and that's kind of what we'll base our exercises and drills throughout the course of the year off of. So we want to test our facility's ability to handle those situations as they come up. Risk assessments are kind of a pared down version of the larger HVA. The risk assessments are for departments specifically, and it's basically the same form, but smaller for each department. So each department's required to fill one of those out annually so that we can identify through that any of the risks associated with hazmat, safety, security, things of that nature. And then again, we will plan our drills and exercises based upon what is provided in that data from those folks that fill that out. Questions on that? Awesome. So this is what you will find. You'll find kind of the pared down version of it on your badge. It just has the images of it and the names. But this is a little bit more detail on kind of what constitutes these code responses. And just go through it really quickly. Code blue, there's a specific group of folks that are going to be responding to that. Fire, there's a fire response team. So again, if code red is announced overhead and it's not in your area, then you don't need to respond. You need to just make sure that your area is ready to evacuate if it's required. But there is a fire response team that's going to be going to the actual announced location. Same with code orange. If you're not in the immediate area, you do not need to respond to that. And we have spill kits and so forth in the pharmacy or in the lab that are dedicated to being deployed in case of a code orange. And again, the code silver, you don't want to go running to whatever area is announced with the code silver. That's obviously a very dangerous situation. An amber alert, we have a pretty wordy policy that kind of lays out everybody's roles in code amber. And just kind of, really briefly, that's getting to exits, And, if somebody's walking, briskly trying to get out of an exit and they got a duffel bag and something, hey, excuse me, can I look in your bag? We're having a code amber drill or amber, alert. And then that's kind of how we would vet people as they go out to make sure that if an infant was abducted, that we are checking it and trying to prevent that from happening. Internal triage. I want to make it clear that an internal triage, if that's announced overhead, that does not mean a bomb threat exclusively. That can be a number of things. We had a code internal triage a month or two back that was a domestic hot water line was disrupted. So that's a system that we need that's going to, that its failure is going to disrupt our normal operations. That's an internal triage. It's not just a bomb threat. So I want to make that clear. We had a couple bomb threats a couple years ago, and it really has kind of got everybody on edge with that, which, again, we don't want to take it lightly, but if you hear code internal triage announced overhead, you don't have to assume that that's what it is. There will be more description coming. External triage, that's going to be, like I said, our severe weather, mass casualty events. If we have a bus crash or something like that, and we have an influx of patients, then that's going to warrant us announcing an external triage as well. Code gray, that could be a combative person, somebody that's, becoming physically violent. It could even be that they're verbally violent and we think that it might escalate. We can call it a code gray, and then people will come and respond to that area and just try to talk that person down, de-escalate that. If it doesn't work from our staff trying to de-escalate, then police can become involved and they can help with that as well. Then our rapid response team, that's going to be a designated group of folks that are going to respond to medical emergencies. And then whenever a code is clear, it will be announced overhead. So for instance, if we have a code red, it will be announced when the pull station is pulled, code red will be announced. Code red, whatever location, 3 times. And then when it's over, it will be code red, all clear, 3 times. So that will be the process for calling each of these codes off. So when it's announced overhead, it will be 3 times. When it's cleared, it will also be 3 times. So, any thoughts or questions on any of that? Awesome. I think it's time to turn it over to our Chief Information Officer, Mr. Payne Francetic. Thank you, sir. I'm not sure what you need.
I don't need anything.
Excellent. That's easy.
That's easy.
Thanks, guys.
Hey, everyone, welcome. I'm Payne Francetic. I'm the Chief Information Officer. I love coming to meet new people when they're coming into the organization. I was reflect back on when I was here, coming through doing the same thing. Everything was amazing. Hospital was new for me. The town was amazing when I came here. So when I came here, I was like, this little tiny hospital, this little tiny town, not big city. But I was thinking, this little tiny hospital, this little tiny town, surely I'll find something bigger and better, but I'll find something other years. Figure that in that still can't understand something. But that was like 34 years ago. So that's what I found, and I think all people find, is that this is a great place to work, and this is a great place to live. If you're new to this area, this is a great place to live. I met my wife actually through the hospital, having 3 kids, and they've all, gone through the schools, and actually all graduated from school and I now. But this is a great place, so hopefully you'll find that too. So, but one of the things that happens when you're at a place for a long time is kind of start wearing different hats and taking on different responsibilities and stuff. By the way, so I'm the Chief Information Officer. 34 years ago, I was not the CIO. We had like 1 computer in the hospital. I was not the CIO with 1 computer. At that time, I actually came here. I was more on the clinical side. I was a respiratory therapist, and I did that for a number of years. And then got into like leadership roles, and then started taking on others, management and stuff over years ago. So, the reason I mention that is one of the hats that I wear, one of the things that I'm responsible for, is privacy. I'm the privacy officer. So, take over into effect. I became the privacy officer for it. So, you guys all remember, so I just want to talk about HIPAA for so long. So,
Anyone remember what HIPAA stands for? You guys have all gone through like the online competency pieces. Anyone remember what HIPAA stands for?
Health information. Privacy.
Glad you said privacy. Glad you said privacy. There's only one P in there, so it's not. Actually, so it's almost like a trick question. It's actually stands for Health Insurance Portability and Accountability Act. So it doesn't sound like anything to do with patient privacy and stuff. So it's kind of a trick question. It was originally like a law that went into effect that was meant to make sure that people could take their insurance when they went. And then it kind of evolved into all these like coding things and all this stuff to standardize for billing. But then it became, then they added in all these like privacy things. So now every HIPAA is kind of moved to that piece of it, the privacy piece. So that's good. And that's what I want you to think of as patient privacy. So when the law went into effect, it's not, it's some laws, some of those federal regulations, just onerous. This was one that really was like probably a good idea. It wasn't like we weren't in healthcare, healthcare industry. Not like we weren't, taking patient privacy seriously and protecting patient privacy. But this just kind of like set a minimum bar. I'm sure everybody was like doing it at a minimum level, and so that's why we put it in place like that. It hasn't changed a whole lot. It's changed a little bit over the years, but not a whole lot. So, and I'm certified in healthcare privacy and security. My certificate number is number 4. So I was one of the early people who became certified in that. So when I looked, I read all the regulations. If you've ever seen anything in the Federal Register, it's like a 2-point font, like super small, and it just goes on for pages and pages and columns. So I've read all of that, so you guys don't have to, and I'm going to simplify it for you. It's very simple. If you remember this, you will avoid jail time and fines and all those bad things. Just don't share any patient information with anybody that doesn't need to know that information. And so that sounds simple, right? But I think what happens, because we had breaches here over the years, we had to let some people go because they shared the information inappropriately, seriously. But usually when I'm sitting down and I'm talking to people, it's like, why did you share that information with me? Usually what I hear is a couple things. They'll say like, well, yeah, I just shared all that information with my spouse or maybe friend or whatever, but I never said their name. So that's the first sort of misconception. If you don't say their name, that you can share anything else with them. So that's the most common thing. And the other is like just that they didn't realize that that meant they couldn't share. It's like, well, I wasn't trying to do anything to harm. I wasn't trying to I'm not selling it to drug companies or anything like that. And that's usually the case. It's usually like that. So, as far as like how much information you have to remove before you can share it, but HIPAA is actually very specific. I think there's 18 different things that it was. If you remove all these 18 things, then you can share information. It's considered de-identified. So the 18 things now are, yeah, patient name is on there. The other things are like pretty much the date that's associated with the patient, including their like date of birth. A lot of data services. Geographic location, more specific than the first 3 digits of the code. So that's like Idaho. So as soon as somebody starts talking about a patient and they say, this patient that came into the hospital today, all right away, you say anything else and you've breached HIPAA because you just shared the date of service. And you're talking about them coming into the hospital here in Moscow. So most likely they came from an 838 zip code. So you shared that, and then it's pretty much downhill from there. So the safe thing to do is to not talk about patients outside of of anybody that's not involved in their care. And by the way, there's 18 things. The 18 things and anything else that can be used to identify the patient. So it's really more than probably. It's anything that can be used to identify. So there's some exceptions, I guess, for share. Well, first of all, so you can share information that's related to the patient's care. That's probably the most often. Right? So you share with other nurses and doctors' offices and hospitals, as long as it's for their care, you can share information. The other two things that you're allowed to share information on is payment. So, a business office, they're not called to share, but they have some information. They don't need to have a whole chart, but they have some information so that we can get paid, so they know the patient's name, diagnosis, social security number, and all those things. And they share that with an insurance company. They share it with the guarantor, the person that's going to be paying. Somebody else. So we can share that information. And then the third category is what they call normal healthcare operations. So there's some things, sometimes we have to share information just because of the way we do business. So for instance, we're accredited by the Joint Commission. So when the Joint Commission comes in, we're not on care, payment, but we still need it so that they can accredit us and do their assessments and their surveys. They have to have access to patient information. Look at that information. So there's some things like that. And there's other business associates that might have access to information, maybe an attorney or coding company or something like that. But there's different places like that that are considered just sort of normal healthcare operations. So it's treatment, payment, and normal healthcare operations. We can share information for it. Otherwise, we can't share. What else can I think? So there's so that's simple, right? Don't share any information with anybody. So there are some like exceptions. It's like if the there's some things like the Department of Health and Human Services can look at information if they're investigating something, or the Secret Service would have access to information, and if president or somebody was going through or something like that. I mean, there's some things like that, but pretty rare, unusual type things that people see. There's some more common ones. So anybody here working like a front desk, office kind of thing. Okay, so you like first contact with like patients and stuff. So one of the things that it allows is for you to share two pieces of information if someone comes up and asks for the patient by their full name. If you give a full name, you can tell them where they are in the facility and give them a brief description of their conditions. They're up on second floor in a stable condition. Most of the time, you're probably not going to share their condition, but you're allowed to say, just for location, you're allowed to say, yeah, they're up on second floor, you go up there and check in. That's one exception. Then there's, one that I get a common question about is, I'm trying to make it seem something like, just don't share any information with anybody. But then someone inevitably will be faced with a police officer, badge or gun, stand in front of them and ask them questions about a patient. Surely I should share information with these guys, right? So most of the time, no, for something like law enforcement, you can't share information with them. But there are some that they're trying to, if they're investigating a crime that took place on premises here, or that's one of us, an employee or something, we can share some of that information. Under certain circumstances, we can share some information and using limited information with law enforcement. In those cases, the best thing to do is to say, hold on, I'm going to go check with somebody, find out what all we can share, and then check with your department director or supervisor or me. And so that's probably a good thing that we do. That's probably what I'm here. I'm here as a resource for you. I'm here as an advocate for our patients' privacy, obviously, but I'm also here as a resource for you. Questions, you're wondering about stuff, in a weird situation that doesn't seem like it fits in that nice neat little box. And you can call me all the time. My phone number is available everywhere. You can ask me. If it's something that could wait, you can, it's just like, I'm just kind of wondering. You can email privacy@griffin.org and I'll respond back to you. Happy to do that. Or if you think more education is needed in the area, or you notice something, we're all required to important. If you notice that there's some breach happening, let me know. It's not meant as like, get that person in trouble. Most of the time, it's like, there's like a process that needs to be looked at and changed so that we're not exposing that information that might be another thing. So that HIPAA does not make a distinction between an accidental disclosure and an intentional disclosure. So either way, it's a breach, and either way, there's fines and possible jail time associated with it. So if you have a piece of paper with patient information on it that you forgot to take out of your pocket and walking across the parking lot, and it falls out, and somebody else sees it, that's a breach. It's accidental, but it's still a breach. So we need to be, HIPAA encourages us to not just do those obvious things to protect patient privacy, but also to take those measures to make sure that we're not being careless with it. So that's it. It's simple. Don't share any information with anybody that doesn't need to know that.
Does that go to as simple as like you're seeing someone you recognize in the waiting room and talking to a coworker?
Yeah, that's it. That's a great question. So the question was like, well, if you see someone you know, right, that that's walking down the hallway in a waiting room or something like that. So we don't want to be rude. We don't want to ignore them necessarily, but we also want to be prying into like, hey, why are you here? So what I would do in a case like that is acknowledge them, say hi. If they want to share more information or engage you more, they will. But I would not, pry. I would just, but definitely don't ignore it. Just it's like, oh, I know that person. Yeah, but I don't want to,
You want to make sure I'm like just good to add nuance as it goes, as far as like as simple as saying, like you shouldn't say, oh, I saw my friend over in the waiting room when I talked to a coworker.
Yeah, right. Yeah, you don't want to say that. You don't want to go home and tell your someone else that like, oh, I saw so-and-so waiting. Wonder why they were there. We don't want to do that. The other thing, so this is a fact about that, because one of the other things that happens to be tricky, it's not really a HIPAA breach, but let's say you did engage that friend of yours that was here, and you're talking to them, and they say, no, that's fine. You can tell everybody you want. I don't care who you know that was here at the hospital. Okay, well, now you have their authorization. So now you go home and start telling people that, like, yeah, so-and-so was at the hospital. Well, they don't know that you got authorization from that patient. All they know is you work in the hospital, and now you're talking about patients. And so we need to be, even in those cases where you have authorization, we need to be super careful about how that comes across to other people in the public. So best thing would still be not to share that information. But if you do go out of your way to say, I would normally not share this information, we protect our patients' privacy, but in this case, he or she gave me permission to share that information. Something like make it really super obvious, because they're going to go tell the next person, and they're probably not going to add all that extra stuff, right? They're just going to say, Michael told me you were talking to so-and-so's under here. So be cautious about that. Part of that's just the percent. Any other questions? Yeah.
Students or shadowing, that kind of stuff. What's the policy in Griffin?
Yeah.
Looking at patients.
Yeah, so students are considered, so when HIPAA covers all of you as like employees, but also they really refer to a broader sense of our workforce. So that includes students that might be coming in, volunteers that might be here. So every one of them that comes here that is in contact with patients should be getting some HIPAA education, just like you guys did. You guys did a little more extensive with online competency pieces and going through the HIPAA. Some of the volunteers probably they still get some HIPAA stuff, but it's a little more abbreviated because they're not having as much direct patient contact. Students usually are getting HIPAA training from whatever course they're in, and then they come in and they kind of assign some stuff saying they've got that, and we have an agreement with the school or whatever it says we have. So as far as what they can have access to, they can still, you're using it for like education, you're using it for, obviously not just, if you just like open things up and start flipping through things, but you can help student, and that's how they learn in practice. It's by showing them that information and using it for education. Does that answer? Is that kind of what you're thinking?
Yeah.
Okay. Anything else? Well, I'm gonna stay for lunch, and I'll be back later to talk about some more IT specific things. Welcome to Britain. If you're new, welcome to the area.